We are live, we can start now.
Linux Laboratories. Live, integrated and excited. Partnering with medical fraternity. Linux is a people and process-oriented global pharmaceutical company. Celebrating more than a decade of excellence in CNS. Linux offers unmatched value in everything we do to doctors, patients, and caregivers. Linux is a top-ranked CNS company, and today the industry is following us. With persistent effort, Linux spreads its wings in dermatology to make millions look good and feel great, to spread smiles head to toe, to maintain, nourish, and enhance skin health. Introducing the latest, youngest pride of Linux. Linux Dermascience offers endless innovative products like Oxyten, Active MF, BioRite, Acnestol, Protect, BioSkin, Castle, and HiKids. Linux Dermascience needs your care to blossom. Linux Laboratories, Linux Dermascience, live, integrated and excited.
Thank you so much. A very warm welcome to all the delegates and members of Nail Society of India. A very good afternoon from my side. So today we will be going on with the fourth skill-based CME, which the Nail Society of India has been doing over the past couple of months. So this is the fourth CME in the series, and it will be covering a very important and very unique topic of nail fold capillaroscopy. To start with the proceedings, I would like to invite Dr. Sushil Tahiliani, sir, who is the President, Nail Society of India, to give his welcome remarks.
So greetings to everybody from the Nail Society. We welcome you to one more skill-based CME. And I will tell you, nail onychology is a subspecialty of dermatology which is coming out of hibernation. And here we have super specialists from our team who will talk to you about a very niche and focused area. They'll tell you how to use a dermatoscope to study the nail folds, not the nail plate, the nail bed, but only nail fold. And they'll tell you the value of analyzing the findings well to be a better dermatologist and to interact with the physicians to help them be better physicians. With these few words, I hand it over to the Master of Ceremonies to invite the first speaker.
Thank you so much, sir, for the warm welcome remarks. And to start with the proceedings, it is always a good idea to start with how the anatomy of the nail fold goes and how the evolution of nail fold capillaroscopy has evolved over the period of time. To talk about that, we have a very young and dynamic speaker, Dr. Kumudhini Subramaniam. She is the Chief Dermatologist at Deep Skin Dialogues, Chennai. Over to you, Dr. Kumudhini.
Thank you very much, sir, for the kind introduction. So here I am to talk about the nail fold microcirculation and the evolution of nail fold capillaroscopy. So first, let's talk about nail fold microcirculation. What is microcirculation? It is defined as the circulation of blood in arterioles, capillaries, and venules. The capillaries in turn are formed by an arterial limb, capillary loop, and a venous limb. The main function of microcirculation is capillary exchange, which is delivery of oxygen and nutrients to tissues and removal of carbon dioxide and waste products. So first, before going into the nail fold microcirculation, let's have a small idea about the nail unit. As we all know, there are 6 main parts of the nail unit, which includes the proximal and the lateral nail fold, the nail plate, the nail bed, the nail matrix, and the distal hyponychium. So we will be talking about the proximal nail fold microcirculation. This is the part where we'll be seeing the microcirculation today. which is used by dermatologists and rheumatologists worldwide to identify a lot of diseases which are concerned with rheumatology and dermatology. So coming to the nail fold microcirculation in capillaries is routinely evaluated within the skin of the nail fold. The entire skin has many capillaries throughout the body. But however, those capillaries run perpendicular to the skin surface and only the tip of the loop is visible. In the nail fold, on the other hand, the terminal rows of capillaries run parallel to the skin surface and all the morphological details and the nature of blood flow shall be examined. It is, however, difficult to analyze capillary function in humans due to the limited access to the vascular bed. This is where the capillaroscopy plays a role. It is a non-invasive way of determining the microcirculation. Capillaroscopy is used for assessing microvascular changes in the peripheral circulation. Capillaroscopy is the most practical technique for instantly visualizing skin capillary circulation and for assessing capillary density and blood flow velocity. Microvessels in the papillary dermis range from 10 to 35 microns, considering those in the mid to deep dermis vary in size from 40 to 50 microns, with an occasional arteriole as large as 100 microns. So coming to what a normal nail fold microcirculation or capillaroscopic view looks like, they will be arranged homogeneously. They'll have uniform morphology at a density of 30 linear capillaries per 5 millimeter, and there will be no architectural derangement. So this is how the normal nail fold microcirculation will appear with no architectural derangement and with 30 capillaries per 5 millimeter. And why is there hairpin shape of capillaries present? The capillaries in the proximal nail fold flow parallel to the surface of the skin, with each capillary being U-shaped with two arms forming a convex loop distally resembling a hairpin. The hairpin shape is noticeable in the nail fold areas and where the outer layers of the epithelium are thicker and the microvasculature has hairpin shaped capillary loop patterns. It is also seen in the lip mucosa and the buccal mucosa in the similar way. This is the hairpin shape. Coming to how the nail fold capillaroscopy should appear in the healthy individual, there should be a density of 9 to 13 capillaries per millimeter. There should be an orderly arrangement of the capillaries, and there should be an afferent branch with a 6 to 9 micron meter diameter, an efferent branch with 8 to 20 micron diameter, and a capillary length of 250 to 500 microns. So amongst this, the capillary density is the most important parameter. It is defined as the number of capillaries in a 1 millimeter length of the distal row of each finger or toe. This capillary density is directly related to age because younger children have fewer capillaries, and as we grow older, the capillary density increases. And gender differences, however, do not have a large impact. And capillaroscopy is possible better in skin with lighter pigmentation, and it's difficult to perform on a darker skin. Toenails have lesser capillary density than fingernails. It is advisable to calculate the mean capillary density value for each finger from the analysis of 4 fields on that finger. The mean value will be obtained, that will be the number of capillaries in that tested finger. There are 2 ways to find out the capillary density. The direct observation technique, where the capillary loops are observed directly and those considered to be the distal loops are marked like this. The distal loops will be marked. And next is the 90-degree method, where a capillary loop will be considered as a distal loop if the distance between the apex of the capillary and the apex of its adjacent 2 capillaries is greater than 90 degrees. Then the next 2 important parameters which we should be knowing is the capillary width and the capillary length. So capillary width is the distance between the rightmost and the leftmost area, and the capillary length is the distance between the topmost and the bottommost area of the capillary. So enlarged capillary is one where the capillary width is increased. So it should be at least 4 to 10-fold increase to call it as an enlarged capillary. The 3 types of enlarged capillary loops will be an enlarged afferent capillary, an enlarged efferent capillary, and an enlarged apical capillary, and also a horseshoe-shaped giant capillary loop, which is enlarged completely. And this is a capillary scoring system where it says 0 is a normal capillary, 1 is borderline, and 2 is definitely enlarged, and 3 is extremely enlarged, which is more than 4 times of the normal diameter. There's another scoring system by Dink et al. Where 1 score means presence of focal enlarged capillaries, and 2 means presence of frequent enlarged capillaries. And coming to an elongated capillary, where the capillary length is longer. Physiologically, capillaries in a person's identical fingers have a similar length, which varies from person to person, and in physically altered fingers. So diabetes patients have a shorter capillary of only up to 10 micron length, and it's called shoal of fishes or elephant nose. Capillary loops longer than 300 microns are called elongated. Coming to some variations in capillaries, the normal range of finger capillary density and morphological variations depend on the age, sex, and ethnicity. And there are some morphological variants like tortuous capillary, where the afferent and efferent limb are curled but do not cross. A crossed capillary, where afferent and efferent limb cross at least at 2 points. Cutillitis capillary, where the limbs are not visible, only tiny red dots are seen. Dilated capillary, where a capillary whose venous limb diameter more than 20 meters or arterial limb is more than 15 microns. And giant capillary, capillary with arterial or venous limb diameter more than 50 microns, also known as mega capillary. And elongated capillary, ramified capillary, bushy capillary, and meandering capillaries are different variations of capillaries. So coming to the second part of the talk, which is the evolution of nail fold capillaroscopy. The history of capillaroscopy starts somewhere in the 17th century, where Mr. Johann Christopher Kohlhaas, the first clinician, he used a primitive microscope to observe the small blood vessels surrounding the nails. And then it was Mr. Giovanni Razzori in the 18th century who used a magnifying glass to find the first relationship between conjunctival inflammation and the presence of knot of capillaries. The main person, the significant person here is the Maurice Raynaud in the 19th century, who presented his thesis on local ischemic damage of the hands, feet, nose, and tongue, and intravital microscopy or capillaroscopy. It became recognized as an important investigation in identifying and analyzing microvascular involvement, which is the key feature of Raynaud's phenomenon. The last century has been characterized by the optimization of these capillaroscopic tools. The various optical devices which are being used to perform capillaroscopic examinations include the ophthalmoscope, the dermatoscope, which has 10 to 20 times magnification, the stereo zoom microscope with 20 to 50 times magnification, and the video capillaroscope. It is best to perform the examination with digital video capillaroscope, which includes a digital video camera and a microscope. In addition, it can be used also as a handheld probe in any situation. This feature enables physicians to examine patients with severe finger flexion contractures as well. So this is a comparison between the capillaroscope of the early 20th century, compared with the new digitalized nail fold video capillaroscopy of the 21st century. And coming to the gold standard, it is considered that high magnification nail fold video capillaroscopy of 200 magnification is currently the gold standard for nail fold capillary examination. However, a handheld dermatoscope is also used to find out the minute intrications in the nail fold architecture variations. So comparing the capillaroscopy and dermatoscopy, capillaroscopy requires special equipment and it requires specialized centers and it consumes a lot of space, whereas the dermatoscope is simple, quick and inexpensive. It is easily available and it is very handy to use. Coming to the prerequisites of a nail fold capillaroscopy, the patients are asked to stop taking caffeine and smoking for 4 to 6 hours before the examination, and patients are instructed not to remove their fingernail cuticles for 1 month to avoid microtraumas that could put them examination at risk, and physically injured fingers should be excluded from the examination. To improve the visibility, magnifying power of optical probes can be used from 50x to 1000x. Also, we can use a mode of gel like a vegetable oil or an ultrasound jelly. Here, only vegetable oils that are skin friendly, such as walnut oil, cedarwood oil, olive oil, and peanut oil should be used. And applying common immersion oils may cause skin and mucous membrane irritation. Why the fingernails are chosen? Fingernails are chosen because there are no limitations on the number of fingers, and there is no particular fingernail that is used. Few choose 4th and 5th fingers of both hands because of the greater transparency. However, some of them choose to see all the fingers of both hands except the thumbs to see any minor changes. Although the microscopic examination of fingernail folds is widely practiced nowadays, this technique is not common for toenail folds. This is because the toes of healthy subjects have significantly lower capillary densities than their fingernails. Different qualitative, semi-quantitative, and quantitative methods are employed in capillaroscopic studies. The architecture of the nail fold microvascular bed, shape, and distribution, homogeneity of capillaries, and the morphological characteristics of single loops are evaluated by the qualitative and descriptive approach. What is the importance of nail fold capillaroscopy? A single abnormality in Raynaud's phenomenon, such as a giant capillary, is highly suggestive of an underlying connective tissue disease. And recently, the American ACR and ULR criteria of scleroderma includes nail fold capillaroscopy as a major criteria. And after that is included, the sensitivity of the entire criteria has risen up to 95%. The advantages of the system is that in a systemic disease with vascular damage, abnormalities in capillary morphology can be observed long before the onset of clinical symptoms. In patients already diagnosed with a systemic disease, damage to the capillaries may reflect the involvement of internal organs and help determine the stage of the disease. There are a few limitations as well. Apart from connective tissue diseases, more common medical conditions may be a cause of peripheral microangiopathy. In the course of both diabetes and hypertension, severe capillary alterations can be observed with heterogeneously enlarged loops, capillary loss, and neoangiogenesis. A pathological capillary image may also result from prolonged exposure to vibration, chemical agents, ionizing radiation, and other occupational factors. A wide field microscopy performed with a stereo microscope can have low reproducibility due to qualitative and subjective assessment. A video capillaroscopy requires skill and precision to perform properly, since even small pressure on the probe on the nail fold can disrupt capillary blood flow and influence the study results. So coming to the conclusion, capillaroscopy is one of the benchmark methods for non-invasive examination of the microcirculation. The simplicity, safety, and non-invasiveness of the nail fold capillaroscopy is invaluable in detecting an underlying connective tissue disease and many other systemic diseases. Thank you very much for giving me this opportunity.
Thank you so much, Dr. Kumudhini, for such an elaborate presentation on the anatomy as well as the evolution of microcirculation. So moving on to the next session, which has been the core behind the concept of these skill-based CMEs, that is the live demonstration of the various techniques that we have been doing during these skill-based CMEs. So we'll be doing the live demonstration of how to do the nail fold capillaroscopy with different instruments. So starting off, we'll be starting with the video-dermatoscope. And for that, we have Dr. Arzoo Mishra with us. He's working in the United Institute of Medical Sciences, Prayagraj. Dr. Arzoo.
Thank you, sir. A very good afternoon to all. And I will show how to use a video dermatoscope, mainly for nail fold capillaroscopy. And first, so before that, I will introduce to how to use this instrument and what are its different parts. So this is the handheld. This is the video dermatoscope. It has much higher magnification as compared to handheld dermatoscope. So coming to its parts, so there is this is a sensor. This is micro touch sensor. When we click on this, when we touch this, then we can take photographs. So it can we can do setting as single click or double click to take the photographs. Then this is the USB cable which is connected to the computer, and then this is the magnification adjustment knob. When we move this, as in this, we can see that there are various markings which are there of magnification. The magnification which we want, we can adjust to it. Then this is the polarizer. This is polarized mode. This is unpolarized mode. Polarized mode is mainly for deeper structure, like in nail fold capillaroscopy, we want to see capillaries. So we use a polarized mode. And in case of superficial structures like scales and other superficial structure, we use non-polarized mode. Coming to this, these are face plates, and there are various type of face plates which are available. And most of them have two focus, but one of them has single focus. I am just showing the other face plates. This is the one it is having single focus. Other face plates are also there, like this. This is a conical face plate, which is more useful in seeing deeper structures like capillaries. And similarly, there are others. And so how do we perform nail fold capillaroscopy? And one important thing is the LED lights which are there in this. And when we move this magnification knob, then the LED lights it come forward and backward. Then there is camera also, which is there in this. Inside this, there is camera inside this. So now how do we perform nail fold capillaroscopy? Like I will demonstrate using this video dermatoscope. So I am sharing my screen. So this is the how the LED lights gets on when we use it, and there is camera inside it that I have already shown. So we keep the video dermatoscope like this, and then we get the image on the computer. So I'm just showing after clicking the image. So we do it on polarized mode. So as you can see in this is a central mark which I have marked. This is higher magnification, and the lower magnification. This is the lower magnification. So as we can see the nail fold capillaries in this. This is the left side of that mark, the central mark, and this is the right side of that central mark. So this marking can be used to calculate mean capillary density, which is important in when we are studying diseases like diabetes, hypertension, or systemic sclerosis. So this is lower magnification. Now coming on the higher magnification. On higher magnification is more appropriate to study the qualitative any morphological change which capillary is showing. So like in this we can see the there are tortuous capillaries in this, that we can see. And usually for nail capillaroscopic changes we use little finger and ring finger, because these two fingers are less prone to trauma induced changes, so that can be a confounding factor when we are looking for the changes. So in that case we mainly use little finger and ring finger to study the capillaries. So as you can see the various capillaries on the image. You can see so various morphological features which we can study is like capillary dilatation, as it was being discussed in the last talk. That is capillary dilatation, enlarged capillaries, then avascular areas, then microhemorrhages, then meandering capillaries, and these are the morphological changes which we can study in this. So that's what I was showing. So in this way we perform nail fold capillaroscopy using a video dermatoscope. Thank you for giving me opportunity to speak on this topic. Thank you.
Thank you, Dr. Arzoo, for demonstrating a video dermatoscope and how it can be used for performing the nail fold capillaroscopy. Moving on, we'll now be discussing about how you can use a more commonly available tool with the dermatologist, that is a contact dermatoscope, and how you can use a contact dermatoscope for performing the nail fold capillaroscopy. To help us with that, we have Dr. Shazia Jelani, who is working as assistant professor at Department of Dermatology, Venereology and Lepidology at Government Medical College, Srinagar. Dr. Shazia.
Thank you so much, Dr. Deepak, for the kind introduction. I'll be just taking the more commonly used handheld dermatoscope. Just a short presentation. I hope my screen is visible.
Yeah, it's visible.
Yeah. So it's a demonstration of the technique of nail fold capillaroscopy using the handheld dermatoscope. Basically, I work in a tertiary care hospital where we have a dedicated special clinic that runs on every Friday, connective tissue disease clinic, and we have almost 160, 130 patients in our clinic. We'll be starting with I'll be just going over to the video demonstration part first. Is my screen visible?
Any smartphone will do, whether it's an iPhone or an Android-based phone. And this dermatoscope.
Is my screen visible?
No, your video is not visible. Your PPT is visible.
Okay, just a second.
So I guess you just stop this PPT and start.
Okay. Is it visible?
Ma'am, you need to share the screen.
Is it visible now?
Not yet.
Just a second, give me a second. Is it visible now?
Yes.
Okay. Just let me know if this is running.
This will be a live demonstration of how we are going to use a hand.
Is it visible? Is it running?
It's not running. Yeah, it's running now.
Okay.
Dermatoscope for visualization of nail hole capillaries. For this, what all we require is this is a hand dermatoscope, dermal IDL4. This is the universal adapter that can be attached to the dermoscope as well as a smartphone. Any smartphone will do, whether it's an iPhone or an Android-based phone. And this dermatoscope, it is a simple handheld instrument. So how do we use this? And it is a charging port. You can use any charger to discharge this dermoscope, and it can normally function for half an hour to 8 hours after full charge. The magnification that we get with this dermoscope is 10x. And some of the drawbacks for this dermoscope, as far as the video dermoscopy is concerned, is that is a magnification of 200x, but this has only 10x magnification, and only operator can visualize what all we are visualizing under this dermoscope. The patient cannot see simultaneously what all can be visualized. And this is a dermoscope. So if we start with dermoscope, it has a switch over here. If we press it once, short press, it is kept in on mode. Then when we start the dermoscope, it automatically is in the polarized mode. And if we short press again, it goes into the non-polarized mode. And then if we long press, we can turn off the dermoscope. This is a universal adapter and an Android. So first thing is how we attach this universal adapter. It has a side screw. 2 screws are there. This is for camera adjustment, and this is for attaching to our Android. Like we start with this. So this is a universal adapter that can be attached to all the Android phones. We attach this adapter to the smartphone. We tighten this screw. After that we attach. We see the main camera of the phone. It has a magnetic strip attached to it that attached to the dermoscope head. Okay, so first of all, some of the do's and don'ts while we use the dermatoscope for nail capillaroscope. The hand should be like, if you can visualize the patient, the hand has to be level at the level of the heart, number one. Number two, we prefer, for nail capillaroscopy, we prefer the non-contact mode. For non-contact mode, what I have done, I have removed this contact glass plate from it so that the vessels are not blanch. We have to clean the nail so that any particles, any dust particles that are attached to the nail, they are removed. The patient has to avoid caffeine before 5 hours, and he has to rest at ambient temperature, that is 20 to 25 degrees, for at least 15 minutes. Manicure in case of females has to be avoided for 3 weeks prior, and we have to clean the dermoscope as well as the camera lens. What we have to do now, we put our dermatoscope on, we can use, or we can see all the fingernails, but the findings are more nicely seen in case of the fourth and the fifth because of the transparency. We'll see what all we have to see. For dermatoscope, it has been advised like if we twist the screw, here we can see the 0 mark. If you are attaching it to the Android phone, the clarity or the focus is appropriate at this 0 mark. I'll put on the let's see it at the 0 mark. Okay. I will put on some more of the linkage fluid. Right. So what all we are going to see in a normal nail fold? First of all, the skin transparency. Normally, in case of a normal nail fold capillaroscopy, the skin is transparent at the edge of the nail and the capillaries are clearly visible. Like we can see, the capillaries are in a hairpin arrangement parallel to the nail edge, perpendicular to the nail edge. The background is clearly seen and it should not be hazy. Hazy is seen in case of the connective tissue diseases. Again, the diameter of the capillaries, but that cannot be seen more commonly in these low magnification dermatoscopes. That is normally less.
Ma'am, I think there was some network issue. You need to share the video again.
Please unmute yourself, Dr. Shazia.
Ma'am, your mic. Yeah.
Hello.
Yeah.
Yeah. Are you able to see the recording?
Ma'am, it was. Yes.
Is it visible now?
Not yet.
Okay, just a second. I'll just share it again. Is my screen visible now?
Yes, it's visible.
Okay. Just let me know if it is running properly.
Like we can see, microhemorrhages are not normally present.
Is it okay?
Yeah.
Yeah, no microhemorrhages. These are normal capillaries arranged in a vertical arrangement. So in case of the normal capillaroscopy, we have to look for 9 important things. First is the skin transparency. Then we have to look for the capillary architecture. That means these nail fold capillaries, they are perpendicular to the nail edge. Then we have to look for the background. It should be clear. It should not be hazy. That means these nail fold capillaries, they should be clearly visible. Density, we have already discussed. Then morphology, they are hairpin shaped. Then we have to look for dilated capillaries or joints. Isolated dilated capillaries are not significant. Like in this particular patient, we are seeing here we are having a dilated capillary. It's a single dilated capillary, so it is not significant. We have to look for any signs of neoangiogenesis in the form of bushy capillaries or the coiled capillaries. Then we have to look for microhemorrhages. No microhemorrhages are present in this patient. Also, we have to look for any avascular areas. Avascular area is defined. It can be either focal or diffuse. if we have the absence of two successive capillary loops, that is considered to be an avascular area. For a neoangiogenesis, they should be highly heterogeneous group of these capillaries. A megacapillary, normally it is 4 to 9 times dilated. However, like if we can see this capillary, it is dilated than the rest of the capillaries, but in case of the joints, they are more than 10 times dilated.
For this, I'm just demonstrating that about the density part. If we have to go for the nail fold density, we look in this 1 mm length of this marking. We can look for, if we are here seeing in the distal row 1, 2, 3, 4, 5, and 6 capillaries. In our patients, what we saw about 5 to 7, 5 to 8 was an average capillary density that we saw in our group of the patients. Next, in next few videos, we'll be demonstrating few of our patients of the connective tissue disease. We are having some systemic sclerosis patients. Then we had an MCTD patient and a patient of lupus. This is a systemic sclerosis patient.
So again, this is a patient of systemic sclerosis. In this patient, we can see there are dilated capillary loops. I will try to focus. The capillary loops are dilated in children. Then we are having this megacapillary loop with bushy ramifications. Here we can, this is 2x magnification. This is a giant capillary loop. We are having pale hemorrhages. Again, a dilated capillary loop. This is a case of, this is an early sclerodermoid pattern. This is the third finger. I will put the dermatoscope on the fourth finger. Here again, we can see there are dilated capillary loops. Few dilated capillary loops are present and avascular area is present. Then again, dilated capillary loops. Giant is here present. Again, a giant dilated capillary loops are present. I can see only one avascular area. Again, here it is not able to flex her hands properly too. Grip is weak. So we will do dermoscopy in this patient. Okay. Also, if we can see what is the big advantage of these handheld dermatoscopes, like in this patient, if we use other type of the video dermatoscope, there is a flexion deformity, right? So we cannot put on other scopes, but if we use the dermoscope, we can modulate it. Like I can put my finger or under her hands, and then we can go for the dermoscopy so that the scope fits in properly. So we will start dermoscopy with this patient. This is under 2x magnification. Capillaries are dilated. There are megacapillary loops. Just a second. Right. So there are dilated capillary loops in this particular patient. Then we are having a hemorrhage here. Then again, some avascular areas. Again, dilated capillary loop is present here. Here in this patient, we are, as opposed to the previous patient, we are able to see here there are frequent dilatations present in this. All the capillary loops seem to be dilated. Then there are these megacapillaries are present. Then there are giant capillaries are present. Here we are having one giant, other giant. Then there are microhemorrhages, frequent microhemorrhages. So this is an active SD pattern. Active as SD pattern of systemic sclerosis. Here we are having so many hemorrhages. Then I will put my scope on the other finger. Here again we are having dilatations are present. Only one avascular area is present here. Dilatations are present all through. Then again we are having these megacapillaries. The microhemorrhages are present. I will put my finger. Yes, here. Again, we are having dilated capillary loops are present here. This seems to be a distorted capillary. I will try to zoom in. Yeah, here the architecture is dilated. See, the capillary shape is like this. Here again, we are having a giant. A giant is present here. Dilated capillary loops. Then these micro hemorrhages. We'll put a dermatoscope or the other finger. Other hand. So here we are having dilatations here, or an avascular area can be seen here. Another avascular area is seen here. I will try to select. Yes. So we are having dilatations. Dilatations are present all over. That means these are mega capillaries. Then this is a giant. See the dilated architecture. As this is 4x magnification, right? So that means 40x total. We are using 4 of this and 10 of dermatoscope. We are having a giant here. We are having an avascular area here, avascular area here. Then again, we are having this dilated capillary loops. Let's, I hope we can find, this is the 4th finger of this patient. We will find good findings, right? Right. So in this patient, again, we are having a giant capillary. We can see this is a capillary loop. Then we are having these ramifications here. Here we are seeing some with a long-standing history of systemic sclerosis. Here we can see we are not able to see any capillary loops except from here. We see here we are seeing some form of the giant capillaries, but it's not clearly visible due to the hazy background. Again, there some capillary loops are visible, but here we are having completely avascular areas. Again,
this is basically our third patient, and the patient had a long-standing history of systemic sclerosis, and the background was hazy, and we were not able to appreciate much of the change in this patient due to the hazy background, lots of avascular areas, and few angiogenesis.
Completely avascular areas here. Then the second finger of this patient, again we are able to see non-specific these avascular areas. Few dilatations are seen here. Then we put the finger on. This is the 4th finger of this patient. We are seeing few dilatations are present here. Background is very hazy. Avascular areas here. We have an avascular area. We are having. Here I will try to magnify this one. We are seeing a distorted capillary, a mega capillary sort of thing. Here again, we are seeing the mega capillaries with only, that means neovascularization is taking place in this particular patient with neovascularizations are taking place in this particular patient with avascular areas. This is a late form of scleroderma. This is the magnification back. Or 2x magnification, no capillaries are visible. There are in fact some capillaries, but the background is very hazy. I will try to put on some more fluid in this patient. This is under 2x magnification. Capillaries are not visible in this patient. Yeah, this is the 4th finger because the on the 4th fingernail we are having thin. The skin is relatively thin, so we are able to see the capillary loops. Put it under 2x magnification. Here, if we can see, if there are dilated capillaries, but there are again. Here we are having these dilated capillary loops. Few avascular areas are seen. Few avascular areas, few dilated capillary loops. Then we'll put our scope on the 5th finger. I'll try to adjust a little bit. Yes. So here we are having on the 5th finger we are having dilatations. Basically, this is the left hand of the patient. So we don't have any microhemorrhage sort of thing. We are having only dilated capillary loops. We are having avascular areas here. There is a mega capillary with ramifications. Again, avascular areas are present. So in this particular patient of systemic sclerosis, on the and also if we see, let me see the gross. I will let you see the gross pattern of the finger. This is the left hand of the patient, and this is the right hand. See, there is basically distal tip is also lost in this patient. So the chains are more severe on the right side because the disease seems to be more severe on the right side. Also, the tethering is more on the right side in this patient. Now, this is a case of subacute cutaneous leukocytodermatosis. Here we can see in this patient There are non-specific dilatations are present. Capillaries are dilated. Again, the subcapillary plexus, we can see dilatations. So if we do high magnification, here we can see repeated microhemorrhage. The femoral pattern of microhemorrhage is present. Then below this microhemorrhage, we are having a dilated capillary loop. This dilated capillary loop with a greatly distorted architecture. This one. Non-specific dilatations are the characteristic of subacute of cutaneous lupus erythematosus. Again, the subcapillary plexus that is dilated. Here we can see the subcapillary plexus are dilated, and these non-specific dilatations plus a big capillary loop, giant capillary loop with the dilated architecture, and these repeated microfemoral pattern of these microfemoral pattern of microhemorrhages.
At the last, I had put.
This will be a live demonstration of how we are going. This will be a.
I had put one more, but I don't think that has got merged into the slide. This is a case of dermatomyositis. In this slide, what we can appreciate, all the capillaries seem to be dilated, but all of them are having ramifications. Here we are having the capillary loops with ramifications, bushy capillaries. Here again, we are having these bushy capillaries, then again a bushy capillary, again a bushy capillary is present here again. This was a case of dermatomyositis with a long-standing history. I had other video of mixed connective tissue disorder, but I don't think the time will permit me, and that has not merged into this slide. So thank you so much for watching. Can I stop the screen share now?
Please.
Thank you so much.
Thank you so much, Dr. Shazia, for such an elaborate discussion and demonstration about how to use a very commonly available handheld dermatoscope and how to use it for performing a technique such as nail fold capillaroscopy. So very nicely elaborated. Moving ahead, we will be talking about how to evaluate a particular nail fold capillaroscopic picture and what are the various parameters that have to be taken into account when you're describing certain features in your nail fold capillaroscopic images. To do so, we have Dr. Chander Grover ma'am with us. Ma'am is Honorary Secretary for Nail Society of India, and she's also the Professor, Department of Dermatology at UCMS and GTB Hospital. Over to you, ma'am.
Good afternoon. Am I audible?
Yes, ma'am, you're audible.
Yeah, and the slides are visible, I hope.
Yes,
yeah, thank you so much. Thank you so much, Dr. Deepak, for conducting this program so well. The topic allotted to me today is nail fold capillaroscopy, evaluation of the different parameters. And I bring you greetings from the Nail Society of India. We've had sessions on how to do exactly the nail fold capillaroscopy. What I'll be discussing about today is the various things, the parameters that you are supposed to study. So there is some objectification and quantification of what are the changes that we are seeing. At the end of this session, we hope that the learner would be able to objectively evaluate the NFC findings, not just know that this is a change existing, but how relevant is that change, whether it needs to be taken into account. Identify and calculate the mean capillary density for a patient. Identify and grade the qualitative changes seen in the proximal nail fold with the goal to visualize NFC changes with confidence and report upon them. Nail fold capillaroscopy, as we know by now very clearly, is a non-invasive method of imaging for in vivo assessment of microcirculation. So this is very important. It lets you evaluate vessels as they are in life. This is a non-invasive method because you're not taking a sample away. This you can do repeatedly. That is the major advantage. You can even see the evolution and the resolution of the changes. Now, more and more dermatologists are taking over NFC because of the easy availability of dermatoscopes, which give us higher magnification, even up to 200x, which we just came to know is the gold standard. The microvascular changes are also present in diseases in dermatosis like psoriasis and autoimmune diseases. So it's not restricted to only the use by the rheumatologists. And as we keep on doing more and more research, we keep on coming across more and more newer changes, which we can see because the basic principle being that microvascular beds across the body are affected by the same set of stimuli or the same set of damaging agents. And in the nail fold, we get an opportunity to see them lying very horizontally. The microvascular structure is lying very horizontally for us to be able to actually see what's going wrong in the architecture of those capillaries, what changes they are suffering from. We get to see the macroscopic results of these changes later on in other investigations of the patients. But here we actually get to see the microscopic changes which are occurring in the microvascular bed. How NFC helps? It helps us detect and monitor diagnostic features of diseases. For example, NFC has a separate category, has a separate weightage allotted to it in the revised ACR EULAR criteria for systemic sclerosis. It helps us detect the early microvascular changes which precede the microvascular complications of lifestyle diseases, diabetes, hypertension, etc. So for you to develop a visible change in your vision much prior to that, the microvascular changes have started happening. And if we detect them early, there are chances and there is hope that we could even intervene early or reverse the changes or prevent them altogether. It also helps us monitor the disease activity in the form of early, active, or late disease. And it affects our treatment decisions and it affects the treatment outcomes. We can assess whether our treatment is working or not. Though many of these are slightly high and lofty objectives, which we will be able to achieve only if we have more and more research in this field, but many of them are achievable even today. Over the years, NFC has evolved from a simple handheld magnifying glass for examination of proximal nail fold to the present day in which you have magnifications up to 1000x available. And for a dermatologist in their daily day-to-day practice, you don't need that high magnification because it is difficult to stabilize. Stability becomes an issue as you increase the magnification. So up to 180x is something which most of us can see and most of us can make out the changes. The normal parameters of NFC in health. How does a healthy nail fold capillaroscopy look like? The capillary density should be anywhere between 7 to 12 capillaries per mm. This is as per current knowledge. The morphology is inverted U-shaped or hairpin loop as we call them. Orientation of capillaries is longitudinal to the proximal nail fold. The capillaries are in addition lying parallel to each other. The subpapillary venous plexus may be visible in up to 30% of healthy individuals. It is actually the point from which these capillaries are originating. So this is lying somewhere in the superficial, somewhere in the mid-dermis. Tortuosity of the capillaries, that is, it is normally absent. It is supposed to be normally absent, but because few of the vessels may still be tortuous, so up to less than 5% is taken to be normal. Under normal circumstances, dilated and giant loops, neoangiogenesis, microhemorrhages, peripapillary edema, dropouts or avascular areas should be absent. And the blood flow should be dynamic without any stasis. And the video-dermatoscopes enable you to be able to see this actual blood flowing through the capillaries. The capillaroscopic parameters, as now we are coming down to the objectivization of this whole scenario that I was talking about, we should be seeing the quantitative parameters and the qualitative parameters. Among the quantitative parameters, the one which is predominantly, which can be done and is of use, is the mean capillary density. And the qualitative parameters are many. Some of them Dr. Shazia has just shown you, the dilated, the avascular capillaries, neoangiogenic capillaries. And even in these, further quantification is possible as to what is the severity of the changes that you are seeing. The first parameter we evaluate is the mean capillary density. It is simply put the average number of distal most capillary loops visualized per millimeter of the proximal nail fold. Normal range, as I told you, is somewhere 7 to 12, even up to 14 in some studies. In our study done by Dr. Jakhar, we had 7.63 plus minus 1.12 capillaries per mm in the normal Indian adult. male as well as female. This was average, females have slightly lesser. The preferred evaluation is in 4th or 5th finger, as Dr. Arzoo had told us. And this is how you see the normal capillaries in the proximal nail fold. The factors affecting this density, how does it vary? It is related to the age. Younger children have fewer capillaries, and it again goes down in the elderly age group. Gender does not have a very significant impact. The capillaries can be difficult to calculate in darker skin, so actually interpretation may vary and you may have a falsely low value. Thickened and fibrous skin then tends to have a lower MCD. Fingers have a higher MCD as compared to the toes. How do you calculate? The initial report was by Sebastian et al. Said that consider all the distalmost capillaries. The disadvantage here was that if you start counting like this, then the ramified or the bushy capillaries will be counted as multiple capillaries. Hofste et al. Then said that you do a 90-degree method where a capillary is considered distal if the angle between its apex and adjacent apices is 90 degree. So that means if a capillary is standing like this, then you will count it, but the ramified left-right thing is not supposed to be counted. We commonly use the method that we had devised for this thesis work, started by Dr. Deepak, in which we use the calibration feature of the USB dermatoscope. We count the number of distal-most single capillary in 4 fingers over a span of 4 millimeters and divide the total by 16 to get per mm value. So this is how your USB dermatoscope offers you this calibration feature in which you can see, I'm going to count 1, 2, 3, 4, and 5 as the capillaries in this area. And you can clearly see there is a dropout here and here, which is present. So similarly, what we were doing was actually marking the center of the nail fold with a pen, a marker pen, and then taking one image to the left, one image to the right of this mark, then calibrating 2 mm and counting the distal-most capillary heads here. Now, these were then added. So like you have your over 4 fingers, you're going to have 8 such images. And the distal-most capillaries counted in them are then going to be, the total number is going to be divided by 16 to get the average count. The scoring of capillaries, that is, once you know the mean capillary density, how to interpret it, this is varying scoring systems available. For example, this is the easier one to remember by Cutolo and Smith, where a less than 33% reduction of capillaries is counted as mild reduction, and more than 66% is given a score of 3. This is severe reduction in the number of capillaries per mm. There are other quantitative parameters, including the capillary width, the capillary length, arterial and venous limb diameter, internal diameter, apex width, intercapillary distance. All these are more difficult to calculate at 200 micron, at the 200x magnification that we are normally able to achieve with our USB dermatoscope. So, and plus these measurements are for more sophisticated video capillaroscope and do not matter much once you are seeing the qualitative changes. So like, for example, this is going to be the capillary width. This is the length as to till where it becomes invisible after that because of the deeper level that it is approaching. Coming to the next part, which is the qualitative evaluation. Normal capillaries, as I told you, are going to be homogeneous, orderly, arranged parallel with a regular intercapillary distance. Even in this normal, you have a great spectrum of normal. So there are 3 major morphological patterns which are described for normal. So you have normal, perfect normal, and unusual normal. Normal is said as 2 to 5 U-shaped capillary loops per mm. Perfect normal when there are more than 5 U-shaped loops per mm. And unusual normal pattern where there is at least 1 meandering or bushy loop or at least 1 micro hemorrhages, which is present. And even in normal pattern here, you can see less than 2 tortuous loop is taken to be normal. So as you can see, all the capillaries are not perfect U's. There is some tortuosity which is present, and this is taken to be normal. Another feature that I would like to highlight in this is, just the dilation at the apex is, I mean, for you to call it a dilated capillary, it has to be dilated across its limbs, not just at the apex. There can be a series of abnormal findings in normal subjects. So the criteria keep on evolving and they vary across ethnicities. But tortuous loops are considered to be the most common aberrant finding, which do not have a significance attached to them. That is, can be seen very well in normal subjects. I told you less than 5% is absolutely normal. Neoangiogenesis, avascular areas in decreased density may also be seen in certain normal subjects. And for that, again, you have a similar pattern like we discussed last time of less than 33% alterations per mm being counted as mild aberration from the normal. So there is, even while we are trying to make it quite objective, there is still some degree of subjectivity involved in evaluating NFC evaluating NFC parameters. Now, how does capillary disorganization start? So we have discussed what is normal. The disorganization starts by either the capillaries becoming dilated, which is the earliest sign of that there is an ischemia and the capillaries are increasing their caliber to bring in more blood. There could be formation of microhemorrhages or avascular areas or bushy capillaries, tortuous capillaries, meandering capillaries, and bizarre capillaries. I'll be dealing with all of them individually. So you have the normal capillaries. This is an image and this is the graphic to portray what could be counted as normal. So some tortuosity is fine. It's not a problem. Dilated capillaries where they start getting dilated. So it's not just a tip as in the previous figure. You see the limbs are getting dilated. The tortuous capillaries where they actually start bending in ways, in multiple ways. This is all because some areas are starting to become ischemic. So some areas have to compensate for that ischemia. So tortuosity keeps on increasing as the ischemia goes on rising. Then there is microhemorrhages, and these microhemorrhages is considered as the most reliable marker of disease activity. So if like in systemic sclerosis and these conditions, you often have the question of whether the disease is active or not. Microhemorrhages is one of the foremost signs to be looked for. Bushy capillaries, this is a point in which the ischemia is so much that neoangiogenesis has started and capillaries have started producing more ancillary vessels to accommodate the ischemia being faced by certain areas. And then there is the meandering capillaries, which are crossing over themselves so many times. It's an extreme degree of tortuosity. So dilation is the earliest alteration seen, which is the first sign of microvascular damage, and it's actually a local response to tissue hypoxia. Dilated capillary, we call it the capillary dilated if it is more than 2 times the width of the surrounding next to it, the normal capillary, and giant capillary when it is more than 10 times the width of the normal capillary. So presence of even one giant capillary is suggestive that the patient has a microangiopathy and you should be looking for other changes as well. So here, like you see a microhemorrhage here, and you see these ramifications, but see all the capillaries, either they are absent or they are dilated. Microhemorrhages are clotted blood in variable forms and sizes. It tends to be more distal because of the growth of the epidermis. These are seen as extracapillary brown aggregates. You could have focal microhemorrhages or you could have diffuse microhemorrhages. They are to be differentiated from extravasates and thrombosis. Extravasates will just produce a swelling in that area, not much discoloration. And thrombosis, there you will see the outline of the vessel. So that has to be differentiated from actual hemorrhage occurring in that area, and they indicate disease activity, as I told earlier. Dropout means that a capillary loop is absent from its dermal papilla, and it's the earliest marker of development of an avascular area. So you see 1 capillary, 2, 3, 4, 5th is absent, then 6th, 7th absent, 8th. So these are capillary dropouts. They have vanished from here. And these dropouts, when they become absence of 2 or more adjacent capillaries from the distal row, forming larger confluent areas, it is called an avascular area, and it is indicator of more advanced disease. often an avascular area is going to be surrounded by capillaries with a disturbed orientation. For example, in this image, you see that the dropout, the surrounding capillaries are going to turn their direction slightly. In a avascular area, they are actually going to sprout new vessels to try and provide some nutrition to that area. Like this is an avascular area surrounded on both sides by bushy capillaries. These avascular areas are can further be scored by different systems which are available, not required to remember all these systems because most of the decisions are taken at this level only. This is required only for scientific work where you're trying to actually grade your patients. The avascular areas can be graded as mild, moderate, or severe avascularity. So tortuous capillaries, a capillary is called tortuous when it is curling, but it is not crossing over itself. Normally, less than 5% of capillaries in normal individuals can be tortuous. More than 10% is counted as a patient with increased tortuosity. 5 to 10% is your gray area. So you see in this particular area, the capillaries are becoming more and more tortuous. They are bending over themselves. Meandering capillaries where they start crossing upon themselves or upon other capillaries several times over. For example, this one, where it starts crossing over itself. So this is a tortuous one, but this is a meandering one. This is a meandering one. You can see the limbs are crossing. Neoangiogenesis is evidence of new vessel formation, and it could be in the form of bushy or bizarre capillaries. Bizarre capillaries actually could be a term for anything which is not covered by the previous morphology. And within this category, you have several evolving terms, as I'll just be discussing further. So here you see this is a bushy one developing in early stage. So it has started forming a newer outpouching to provide. So here you see just faded capillaries. I will not call this an avascular area, but this suggests that there is grossly something wrong because of which the capillaries are having to change their morphology. This is one which has two openings and one outpouching here also. So new vessel formation is occurring. And here you have a very proper bush. You can see the 4 different heads that this capillary has. Bizarre capillaries where you can see so many different changes. You see one giant capillary is present here, some avascularity, hemorrhages are present. So where you're not able to classify properly, it is a bizarre capillary. Here also, you can see multiple bizarre capillaries as well as meandering capillaries present. A dilated or a prominent subpapillary plexus is a superficial cutaneous plexus which is normally located in the papillary dermis, giving rise to these capillary loops. So why do you see it? Either you see it because the skin is very transparent, or you see it because the blood flow is very sluggish in that papillary, subpapillary plexus. So the factors include hyperkeratosis, pigmentation, injuries, edema, and sluggish blood flow makes the blood stop there for a longer time. So a subpapillary plexus may be seen in 26% of healthy, 26 to 30% healthy individuals also. It's not always indicative that there is something wrong, but it is much more commonly seen in disease states. Other types which have been described in literature include the criss-cross form or the figure of 8 form, where it is forming a figure of 8 by crossing over the arterial and the venous limbs. It's a normal variant, largely depending on the angle of observation. And dystrophic, again, I will rather substitute the word bizarre for this, where the loops are not well developed or they are regressing, like these. The few types of capillaries which we have described over the years include receding capillaries, where the individual capillaries are maintaining their position in the distal-most layer, but they are presenting slightly proximal. And it appears that the capillary has started receding backwards, but not yet gone. And it was seen in up to 60% of diabetics by Dr. Deepak. You can see the normal level at which the capillaries should be present, and these are the receding capillaries. These were seen in diabetics. Angulated capillaries is a special type of a tortuous capillary where the angulation is, where the bending of the capillary is sharply angulated, where one or both arms of the distal capillary loop are seen to bend at an angle. And this was also seen more commonly in diabetics as compared to healthy controls, or even as compared to the systemic sclerosis patients. So this is an angulated capillary. Here, this is tortuous, so you don't have that sharp bends, but here you can see a very sharp bend which is developing in these capillaries. Capillary disarray was seen in hypertensives in 73% patients, and this was significantly more common than the normotensive population. This we saw in the study by Arzoo. The capillaries here, why do you call it a disarray? Because the capillaries are not oriented perpendicular to the horizontal axis of the proximal nail fold. So, like you see, 1, 2, 3, they are going up normal, but this one will cause a disarray. Another one with disarray. So they are moving away from the normal axis in which they should be present. So it gives a windswept kind of an appearance. To conclude my talk, nail fold capillaries truly reflect our microvascular beds in a very easy, reproducible, and non-invasive fashion. Parametric evaluation of these nail fold capillaries helps us identify even the minute changes, which can then be graded objectively as well as quantitatively. Even then, there is some degree of subjectivity involved. This is a technique with high sensitivity, offering the advantage of a long-term evaluation and follow-up of these patients. And I would say an essential skill which adds value to our practice. Thank you so much for your kind attention.
Thank you so much, ma'am, for such an elaborate and so many images to explain what exactly we mean by all the various parametric evaluations. I'm sure audience would have learned a lot from your experience in doing nail fold capillaroscopy for so many years. Moving ahead now, since we are familiar with the technique and we are familiar with what all parametric evaluations needs to be done while doing nail fold capillaroscopy, we'll now be moving towards the disease evaluation with the help of this technique. And to start off with, I would like to invite Dr. Yogesh Marfatia, sir. Sir is professor at SBKS Medical Institute and Research Center. And sir has also been a past president IADVL in the year 2017. So I'll just share your presentation, sir.
Thank you. So thank you, Deepak, for nice words. And I think I feel a bit at ease because the basic things are explained very well by Dr. Chander. So you can here start with my presentation. Yeah. Yes. Yes. The first slide, yes, this is my designation already explained, and my topic is utility of nail fold capillaroscopy in systemic sclerosis. Next. Yes. So coming to systemic sclerosis, the hallmark of pathologies of systemic sclerosis include autoimmunity, vasculopathy, and fibrosis. So, and we all know that vasculopathy can be very well studied with NFC. Next. Yes. So blood vessel injury could be the initiating injury in scleroderma. There is impaired vasodilator vasoconstrictor balance. What happens is that there is a sort of defective vasodilatation aggravated by vascular damage leading to irreversible progressive vascular remodeling, luminal wall occlusion, platelet aggregation, and ischemic changes. So this imbalance, which is more in favor of vasoconstriction, is there, and this leads to many issues. There is perivascular inflammation in scleroderma. Next. Yes. So increased thickening of and perforation of innermost layers of the arteries, and this limits blood flow, vasospasm, particularly in response to cold. What is important is that consistent monitoring of vascular components at baseline and during follow-up is necessary to ensure that the best measures are taken to control vascular involvement. And this can be achieved by nail fold capillaroscopy, as it reflects many vascular changes and it can offer simple tool to assess vascular component in connective tissue disorder, including scleroderma. Next. Yes. So there is a debate. Are blood vessels primary target of systemic sclerosis? So tissue fibrosis seen in scleroderma patient is the end result of complex biological process involving immune activation and widespread vascular injury. There are compelling clinical and biologic evidence suggests that the primary target for both initiating and propagating the disease is blood vessels. Next. Yeah. So what is this nail fold capillaroscopy? We have already discussed this. This can assess microcirculation and pathologic changes. And you can have a look through the epidermis of nail fold to view the capillaries of distal papillae. Some of the things are coming to the image. So some of the things already discussed: hairpin appearance of normal capillaries, giant capillaries, or dilated capillaries. See, with practice only you can learn this. You have to see so many images or do nail fold dermoscopy, or even angiogenesis can be appreciated if you are having the practice of doing it through capillaroscopy. Next. Yes. So in scleroderma, see, what is interesting is that now nail fold capillaroscopic findings are included in American College of Rheumatology and European Union European criteria also of systemic sclerosis, and it has a great role to monitor disease progression. So in short, nail fold capillaroscopy is now a mainstay investigation in cases of systemic sclerosis and other rheumatic disorders. You can't just ignore it sitting in a clinic. You have to pay attention and do this. Microvascular damage in scleroderma cases can be detected in structural alterations of capillaries. Let us go through the list of structural alterations in capillary. So there is progressive decrease in density of capillaries. There is enlargement of capillaries, microhemorrhages, and signs of both neovascularization and new avascular areas are associated with this. Is associated with decrease in cutaneous blood flow. See, many of these can be very well studied. Next. So what is the role of NFC in differentiating primary Raynaud phenomena from scleroderma? So if primary Raynaud phenomena particularly is associated with autoantibodies, and the changes include enlarged giant capillaries or capillary loss and association with autoantibodies like anti-SCL70 or isotopomerase, whatever we call, then this Raynaud phenomena can be a part of systemic sclerosis. Otherwise, it can be primary and not associated with systemic sclerosis. So it is important to evaluate and try to find out whether this Raynaud phenomena is primary or secondary to systemic sclerosis. Next. Yes. Now coming to, pattern of changes, microvascular alterations in systemic sclerosis. So few giant capillaries, there can be few microhemorrhages, but no evidence of loss of capillaries in early stage. This is important. Relatively well preserved capillary distribution. You can see here in picture that there are early changes in scleroderma are visible. There is slight dilatation, but maintenance of orientation and distribution pattern. Next. Yes. So active disease. So frequent giant capillaries, frequent microhemorrhages. This microhemorrhage you can see in the image as confluent petechiae. Moderate loss of capillaries. Overall, if you have an overview, you can see relatively less capillaries, absence of mild ramified capillaries with mild disorganization of the capillary architecture. So this suggests active disease. Next. Coming to late pattern or late disease. So in late disease, there is relative absence of giant capillaries and microhemorrhages. There is severe loss of capillaries with extensive avascular areas, ramified Bussy capillaries, intense disorganization of normal capillary area. You can see in the image, late changes, giant capillaries, then loss of capillaries. You can see loss of capillaries, and even avascular area. So many of these change are visible in this particular image, in a image of late pattern. Next. Yes. So what are other alterations? The capillary can be tortuous, or there can be meandering capillaries like that, as shown by arrow and star. Next. Yes. So even quantification of nail fold capillary changes is possible using a validated scoring system for both diagnostic purpose and as a clinical biomarker of disease activity and severity. A capillaroscopic skin ulcer risk index has been shown to identify SCC cases at higher risk of developing digital scar. Even cardiac disease is more severe in patient having higher nail fold capillary score. So scoring, like we have a lot of scoring system, and here also scoring is possible or can be done for proper assessment. A reduction of nail fold capillary density is correlated with severity of pulmonary artery hypertension, suggesting an association between cutaneous microvascular changes and systemic vascular diseases. See, even diabetes, I had one study. We have seen this association between microvascular changes and systemic vascular diseases. Next. Forward. Yes. So there is defective angiogenesis and vasculogenesis. So what is the difference between angiogenesis and vasculogenesis? Next slide. Yeah, keep this. So angiogenesis, by angiogenesis means from existing capillary budding occurs, and by vasculogenesis, no, please go back. Vasculogenesis is the formation of new capillary. Yes. So an early and clinical indicator of defective angiogenesis or vasculogenesis is visible in nail fold capillaries. Its profound loss of capillaries is evident along with absence of visible normal vessel formation. Substantial avascular area suggests defect in angiogenesis, and abnormal
I guess sir has got disconnected.
Can we carry on with the next talk, or only the conclusions was left, I think?
Only the conclusions are left, so I'll just finish them off.
Yes, please do that.
To conclude, one of the hallmark pathology in systemic sclerosis is vasculopathy. Sir has joined back.
Sorry for the connectivity problem. Can you go back to 1 or 2 slides?
Awesome.
I'm just concluding. Yes. So coming to this was the where we stopped. So here also there are changes showing this avascular areas and defective angiogenesis. Next. Forward. So you can go ahead. By neoangiogenesis, which is not observed in scleroderma. So to conclude, nail fold capillaries reflect many vascular changes It can offer a simple to assess vascular component. As discussed, it can differentiate primary Raynaud phenomena from scleroderma. Quantification of NFC findings can be done. Higher nail fold capillary score suggests more severe cardiac disease. There is association between cutaneous vascular changes and systemic vascular disease. And NFC also helps to detect vascular complications like painful digital ulcer, scleroderma renal crisis, and pulmonary arterial hypertension. Next. So, coming words of thanks or acknowledgement to office bearers of Nail Society of India and Dr. Chander Grover, Dr. Deepak Jakhar for readily providing me NFC images. All images shown by me or presented by me was provided by Dr. Deepak. I am really thankful to you, Dr. Deepak, for your openness, for learning purpose. And of course, I thanks my PGs who are always backbone while preparing any presentations, and all the participants for patient hearing. Thank you very much. Thank you.
Thank you so much, sir, for covering one of the most common indication of nail fold capillaroscopy, and probably one of the first indications where nail fold capillaroscopy was applied. It was very elaborate. It was very well elaborated by you. Over the period of times, nail fold capillaroscopy has moved from systemic sclerosis to other connective tissue diseases as well, namely the SLE, the dermatomyositis, the mixed connective tissue disorders, and so on and so forth. So to cover this important aspect, I would like to invite Dr. Nirmal B, sir. Sir is a consultant dermatologist and head Department of Dermatology, Meenakshi Mission Hospital and Dermal Square Skin Clinic, Madurai, Tamil Nadu. Over to you, sir.
Yeah, am I audible, Dr. Deepak?
Yes, sir, you are audible. Your screen is also.
Yes, my screen is there. Yeah.
Yeah.
We've heard interesting introductory lectures from Dr. Chander Grover and Dr. Yogesh, and let me take the topic further. And my role is to speak about the utility of nail fold capillaroscopy in other connective tissue disorders apart from systemic sclerosis. My first 2 or 3 slides will be relevant anatomy, so that becomes much more easier. My subsequent slides becomes much more easier to understand. So when you look at the proximal nail fold, what is normal? You should know what is normal, and then you should know what is abnormal. So normally you'll have a hairpin bend, can have mild tortuosity, or it can loop by itself, but it has to be homogeneously arranged. The normal density is 30 linear capillaries per 5 millimeters, or anything more than 7 per millimeter is considered normal. So this is the normal nail fold capillaroscopy seen in the proximal nail fold, which is fairly regularly arranged. And now, how do you differentiate it? The patterns in different connective tissue disorders. It's grossly divided into 2 patterns. The scleroderma pattern, which Dr. Yogesh Marfatia had elaborated in the previous lecture. It's called the scleroderma dermatomyositis pattern, where you'll find capillary dilatation. I'll just take few slides through it. Capillary dilatation, avascular areas, disorganization, budding capillaries, twisted and enlarged capillary, and capillary hemorrhages. And the second pattern, you can call it the non-specific pattern, or the non-scleroderma pattern, or the SLE pattern, where you'll find tortuous meandering loops, which may resemble, extremely tortuous vessels, may resemble a linear glomerulus or SL dilatation. Whereas in this pattern, the dropouts or avascular areas are minimal. So whenever you look at nail fold, I think you have talk on that. Like, you're not supposed to miss a finding. Like, you're supposed to go systematically. And this is one of the checklists which I have published in the International Journal of Dermatoscopy. It is very easy to remember. It's A, B, C, D, E without an F and H. So why I'm telling this again is, why I'm trying to reinforce this again is, like, in dermatomyositis and mixed connective tissue disorders, you will have the same pattern which you find in systemic sclerosis, but there will be minor modifications in the pattern. First, like, you should know which is, like, what is early, what is active, and what is late. In early systemic sclerosis dermatomyositis pattern, you will not find, what you will not find is very important here. You will not find dropouts here. And what you may find is, you may find a few enlarged capillaries, dilated capillaries, and giant capillaries. You may find a few hemorrhages. As the phase goes to active, you will find a lot of enlarged capillaries, giant capillaries, and lot of hemorrhages, and dropouts will start to increase, and the organization or the architecture will start to become, ramified, like how Dr. Chander showed, like, the single capillary lobe, which is convex on the end, will change into, like, it'll start looping, it'll start ramifying, like it becomes two loops. And finally, when you go to the late stage, it becomes extremely bushy with 3 or 4 branches. Background is again important. Like, in early, it is clear, with as you go towards the late stages, it becomes extensively hazy, which is a marker of fibrosis which is happening there. Now, this exactly describes it. Like, as in the late phase, you don't find giant capillaries. The amount of hemorrhages are less. It's more in the active phase, and what you see more in the late phase is, like, the areas of avascularity and dropouts with a lot of haziness. Let's come to this pattern. Like, dermatomyositis, what do you see? You see this pattern of scleroderma dermatomyositis pattern that's seen about 20 to 60% of patients with dermatomyositis. In juvenile dermatomyositis, you can find these phasic changes, like early and late changes. Whereas in the classical dermatomyositis, these phasic changes of early active and late might be less obvious. And the duration is again important. The shorter the duration, it's associated with more severe changes like giant capillaries and decreased capillary density. And when the duration is more, you'll find time for the ramification to happen. So in dermatomyositis, you'll have a strong correlation between the nail fold capillaroscopy and the cutaneous involvement. In juvenile dermatomyositis, the lack of resolution of nail fold capillaroscopy changes will attribute to more severe and more chronic form of disease. And there has been described a link between, like, interstitial lung disease, Raynaud's phenomenon, and malignancy. The nail fold capillary, as the severity increases, you have associated ILD, Raynaud's, and malignancy. So this is my patient of dermatomyositis, where you can see the architecture getting disrupted, and you can see a few avascular areas, and you can see these capillaries getting ramified. And what's more important is, you look at the avascular areas, look at these white areas, look at these yellow areas. So all these can correlate with the changes what is happening in your lung. Like, when you find lots of white areas and yellow areas and lots of haziness in your nail fold capillaroscopy, it means that, like, you have systemic complications like fibrosis or interstitial lung disease is happening. So this is again, like, extremely disorganized nail fold capillaroscopy with lots of avascular areas here, and you also have few microhemorrhages there and dilated vessels. Again, extreme disorganization, another case of dermatomyositis. And this is when you have extensive ramification in those bushy capillaries. Systemic lupus erythematosus. In systemic lupus erythematosus, like this nail fold capillaroscopy involvement is directly related to the amount of injury which is happening in the systemic organs. And nail fold capillaroscopy abnormalities are also associated with anti-dsDNA antibody. This is what exactly meandering means. So river which takes this route, like extremely tortuous route. And this is seen very commonly in systemic SLE, systemic lupus erythematosus. You find meandering vessels, you find tortuous capillaries. What's more prominent in systemic lupus erythematosus, the loop length can increase. Dilatation is not very common in systemic lupus erythematosus, and capillary loss is again very rare. You can have a prominent subcapillary venous plexus. One thing is like prominent subcapillary venous plexus can also be present in somebody having a very translucent cuticles. It's present about quarter, like 20-25% of normal individuals as well. So in SLE, like you may not find all these features, but at least half of the patients will have a normal nail fold capillaroscopy pattern. And when you have dilated capillaries in a patient with systemic lupus erythematosus, then can be associated with Raynaud's phenomenon and gangrenes in lupus patients. So this is SLE, where you can find these elongated capillaries with very little hemorrhage, virtually no hemorrhage seen in the nail fold capillaroscopy. You can see these length increasing and a bit of tortuosity, which is happening here. Again, here there's a little bit of dilatation here. Then coming to mixed connective tissue disorder, the pattern which is seen very commonly in mixed connective tissue disorder is this scleroderma dermatomyositis pattern. And when you find this pattern, it's a good indicator of lung involvement and disease severity. And in mixed connective tissue disorder, like the nail fold capillary changes are more dynamic. So once the disease gets cured and once the disease gets treated, most of these nail fold capillaroscopy changes will get reversed back. So, and if the disease progresses, then you'll have lots of avascular areas happening. So this pattern is seen in about 65% of mixed connective tissue disorder. And when you have avascular areas, it has got a very strong correlation to for the presence of associated interstitial lung disease. So if there is whitening of nail fold capillaroscopy, it means like lung is also getting fibrosed. So bushy capillaries are again present very commonly in mixed connective tissue disorder, which is followed by giant capillaries. And the early pattern, what you find in systemic sclerosis and dermatomyositis, is associated with a positive anti-RNP antibody. So this is a patient where you can find these ramified vessels and avascular areas and extreme disorganization which is happening in the nail fold capillaroscopy. So undifferentiated connective tissue disorder. So nail fold capillaroscopy, when findings are very equivocal, you can't really fit into any connective tissue disorder. Nail fold capillaroscopy will help to put in we'll know like which way the disease is progressing. So the commonest pattern seen here in undifferentiated connective tissue disorder is this scleroderma dermatomyositis pattern, which is observed in about 13.8% in a study. So approximately about 25% of the patients of undifferentiated connective tissue disorder may transform to systemic sclerosis and follow up. So that is why it is important, like nail fold capillaroscopy can pick these pick the way like the disease can transform in future. So it gives an idea of how the disease is going to progress. And Sjogren's disease, again, like Sjogren's, like it's more of the SLE or the non-specific pattern. You can find cross capillaries and confluent hemorrhages on nightfall capillaroscopy. Then you have associated Raynaud's. Coming to video capillaroscopy, you've seen images of images taken through the dermatoscope. And video capillaroscopy offers a very high magnification of 200x, which is actually the gold standard in nightfall capillaroscopy. And but what's the problem with dermatoscopy? It may be less sensitive to these early changes. Dermatoscopy may be less sensitive to those early changes, but even in the EULA criteria, you need to know which is normal and which is abnormal. With which, like, you know, either of these should be okay to find out which is normal and which is abnormal. And even with the dermatoscope, like, you know, you can do a very great nightfall capillaroscopy work. So, but the advantage of the video dermatoscope or your Optilia software is, like, you know, it's got a software which can predict your skin ulcer index. Like, you know, when your index is more than 3.8, then it means, like, you know, you have I mean the digit is the digit has got a risk for digital ulceration. So these are a few images taken in my previous institute when I was with Christian Medical College. So you can actually, this is the normal, this is through that Optilia nail-fold capillaroscope. This is the normal nail-fold capillaroscopy image, and SLE, you can see those mild dilatation and the elongated vessels which you see in SLE or SLE pattern. And this is the late pattern where you can see a lot of whitish areas, a lot of disorganized architecture, and you can see complete chaos. And these are the bushy capillaries, exactly bushy, like how you see a bush with lots of branches. These are the bushy capillaries which you see through the Optilia capillaroscope. So thanks for your patient learning, and I learned dermatoscopy from Dr. Coker. Like, this is way back, like you know, about 8-9 years back in KEM, and that is how I carried my journey on dermatoscopy. So thank you.
Thank you so much, sir, for such an informative talk and very beautiful images of the various changes that you have just shown in your last slides. So moving ahead from the connective tissue diseases, we will now be covering, and since, you know, nail-fold capillaroscopy is gaining popularity, so a lot of theses are now coming up beyond the connective tissue diseases. So we have two presentations from their thesis. The first one would be presented by Dr. Sanjay Kumar, and he will be presenting on utility of NFC in diabetes mellitus. Dr. Sanjay.
Is he there? He's...
So a technical team, can we start with Dr. Arzoo's presentation, the video presentation that he has sent us? Dr. Arzoo's presentation would be on utility of nail-fold capillaroscopy in arterial hypertension.
Yes, sir. Give me a second. I will share.
Previous session in the CME, I have already explained how to use a video dermatoscope. Now, in this session, I will be talking about what are its implications in hypertensive patients. As we know, hypertension is a very prevalent and very common disease, and it is responsible for a lot of mortality and morbidity in our country. So it is very important to diagnose hypertension at an early stage, and it is also important to see the changes, the microvascular changes which we know occur in hypertensive patient early, so that the appropriate steps can be taken to prevent the further grave microvascular manifestation like in kidney or in eyes or in CNS. So it is very important to see those microvascular changes early. So by using a dermatoscope as a nail fold capillaroscope, mainly the video dermatoscope, because in that it is important to see the changes at high magnification also, which is not every time possible in case of a handheld dermatoscope. So using video dermatoscope, we can see those changes even more clearly. So in hypertensive patients, there are various parameters which we look for. First is the mean capillary density. In hypertensive patient, it has been found that mean capillary density is lower than normotensive controls. So I will also show the pictures. And mean capillary density in hypertensive patients is lower than normotensive patients. Simultaneously, I am also showing the pictures. So I'm sharing my screen. So as I said that mean capillary density. So how do we calculate mean capillary density? First of all, just to show that this is one picture which I am showing. In this, we take how do we calculate mean capillary density? We measure, this is the central line of the nail fold. We measure 2 millimeter left of it and 2 millimeter right of it in 4 fingers, ring finger and little fingers of both the hands, and then we add the value, the number of capillaries which are there, and then we divide that by 16, and which gives the mean capillary density. So mean capillary density, this is just to show, this is not in a hypertensive patient, this is in a normotensive patients. So mean capillary density as will be reduced in hypertensive patients, like in this case. So in this case, we can clearly see that mean capillary density is reduced. It is in one of the hypertensive patients, and mean capillary density is a quantitative features. There are other qualitative features which are also to be looked for. Like in this case, we can see avascular areas. These two arrows are showing avascular areas in a hypertensive patient. So similarly, other qualitative features, if we look for, then we see like capillary disarray. We say capillary disarray when the capillaries are not lying not in the straight line, when they are not perpendicular to the horizontal axis, like these are tilted, these are deviated from the axis, like these are on the normal axis, and these two capillaries are deviated. So we also get this capillary array, capillary disarray in hypertensive patients. Then bushy capillaries also, they are more common in hypertensive patients as compared to normotensive patients. And besides that, meandering capillaries, when the capillaries which curl on themselves, like this figure of 8, which we can see in this capillary, are curling on themselves, forming a 8 figure. These are meandering capillaries. These are more common in hypertensive patients as compared to normotensive. Then dilated capillaries. So these capillaries are dilated. These are more common in hypertensive patients, dilated capillaries. And so these are certain findings which are, and I have not told, microhemorrhages are more common in hypertensive patients. So these were the qualitative features which are more common in hypertensive patients. So when we get these features, then it means microvasculature is being involved. There has been study that these features, these features like avascular areas and capillary dilatation are more common in those which in those hypertensive patients which are having ophthalmological and renal involvement. The more these features are more common in the indoor patient, which proves that there is similar microvascular change which is occurring at that level also, which needs to pick up, which needs to identify before the further grave complication. So it is so nail capillaroscopy by video-dermatoscope is helping to prevent those grave complications, which is very important. This is the main implication of nail fold capillaroscopy in hypertensive patients. Thank you.
So Dr. Sanjay has joined. So he'll be talking about the utility of nail fold capillaroscopy in diabetes mellitus. Dr. Sanjay, over to you.
Yes, sir. Good evening to all the respected seniors and panelists. I would be talking on nail fold capillaroscopic changes in diabetes mellitus and its complications. Is my screen visible, sir?
Yeah, it's visible.
So basically, brief introduction. As you all know, diabetes is a chronic progressive hyperglycemic disorder. A brief introduction. Diabetes is a chronic progressive disorder leading to micro as well as macrovascular complications. The microvascular complications include diabetic retinopathy, neuropathy, and nephropathy, while the macrovascular involvement could be a cardiovascular disease or a stroke or a peripheral vascular disease. Nail fold capillaroscopy till now has been used and utilized to evaluate and diagnose mainly in connective tissue disorders like systemic sclerosis, systemic lupus erythematosus, juvenile idiopathic arthritis, and other connective tissue disorders. Since a similar microvascular involvement is also seen in diabetic patients, recent studies have even focused on utilizing the nail fold capillaroscopy in diagnosing at finding the nail fold capillaroscopic changes reported in diabetes. Based on the previous studies, even we tried to evaluate the nail fold capillaroscopic changes in diabetic patients and tried to correlate it with the microvascular complications associated with it. The main aims and objectives of our study were to study the capillaroscopic changes in the proximal nail folds of all 10 fingernails among the diabetic patients, and to assess their correlation with its complications like diabetic neuropathy, retinopathy, and nephropathy, and also to assess their correlation with healthy controls. The secondary objective was to find an association with metabolic syndrome. With the materials and methods, the study was done in the outpatient Department of Dermatology, Venereology and Leprosy in Hindurao Hospital at Malkaganj. The study design was an observational, cross-sectional and a comparative study, which was done for a period of around 1 year. And the study population were all the cases of type 2 diabetes patients who were diagnosed according to the ADA, American Diabetic Association criteria of 2015, which includes a fasting blood sugar level more than 126 mg per deciliter, or post 2-hour plasma glucose level more than 200, or a HbA1c value more than 6.5, or a patient with symptoms of hyperglycemia or hyperglycemic crisis with a random blood sugar level of more than 200. Coming to the inclusion and exclusion criteria for our study, we included all the cases of adults with type 2 diabetes with and without microvascular complications, along with the age and sex matched healthy controls. And also we included patients who were willing to join the study and were ready to give a written consent. Our exclusion criteria was patients who were not willing to participate in the study, who had a history of smoking, who had nail unit infections, or a history of onychophagia or onychotillomania, or any trauma to nail unit and frostbite, and also patients with known connective tissue disorders or on drugs which were affecting the peripheral circulation, and also pregnancy. Coming to the methodology, patients who were diagnosed with type 2 diabetes based on American Diabetic Association criteria and who were consulting to the study protocol were included in our study, and an informed written consent was taken from them, and a personal and familial history of diabetes with the onset duration was recorded, and the clinical examination mainly assessment of blood pressure and body mass index, and along with the waist circumference, and evaluation of Michigan Diabetic Neuropathy Score, which has two criteria, the clinical as well as the nerve conduction studies. Since our hospital doesn't have the facility of nerve conduction studies, we relied entirely on the clinical examination. Clinical examination mainly was to test the sensory, motor, and reflexes. Sensory was we tried to test the senses for vibration, pinprick, and also light touch sensation. And also we tested for reflexes, and also motor testing was done. Based on that, a score of 0 to 46 was given. And based on the scores, we graded them into mild, moderate, and severe neuropathy. And apart from that, fundoscopy was done to all the diabetic patients to rule out retinopathy, and its severity grading was done based on the ETDRS classification, that is early treatment for diabetic retinopathy study. After doing this, we asked the patients to get the lab investigations done, that is urine for routine and microscopic examination and renal function test, spot urine albumin creatinine ratio, and blood biochemistry, which included fasting blood sugar levels and also postprandial blood sugar levels, and a HbA1c value and lipid profile. Based on the spot urine albumin creatinine ratio, we graded the patients into diabetic nephropathy and without nephropathy. That's the value of more than 30 milligram per gram was considered to be significant and was diagnosed, can be termed as diabetic nephropathy. After performing all these investigations, we have done a nail fold capillaroscopy according to the standard protocol on all fingernails. That is, we asked the patients to sit at an ambient temperature for 15 minutes with the hands kept on a dull non-refractile surface at the level of heart. And after applying the linkage fluid, we tried to visualize the nail fold capillaries initially at a low magnification, that is at 50x, to visualize the entire proximal nail fold, and then at higher magnification to look at the individual capillary architectures. The images were saved on laptop using software provided with the dermoscope. After that, after doing all the investigations and tests and performing the clinical examination, we classified patients into 3 groups. This is the group 1 with type 2 diabetic patients with microvascular complications, and type 2, in the group 2 is type 2 diabetic patients without any microvascular complications, and group 3 were healthy controls without diabetes. Each group had around 80 patients. Coming to the results, you can see that almost all the groups had a similar distribution of age and gender in all the groups, while healthy adults had a relatively higher proportion of males in the group. As expected, the mean disease duration was high in patients with diabetes with complications compared to the patients with diabetes without complications. There was no much significant difference between the fasting blood sugar levels and postprandial blood sugar levels in patients with diabetes with complications and without complications. In our study, patients with one or more complications were included in group 1. Among them, 40 of them had retinopathy alone, 14 had only neuropathy, 23 had nephropathy along with retinopathy, and 3 of them had neuropathy along with retinopathy. Hence, we tried to analyze and compare all the groups, all the nail fold capillary parameters in all the groups. And what we found is that the proportion of nail fold capillary changes, be it the tortuous capillaries or the receding capillaries or the dilated capillaries, almost all the capillary findings were significantly or more frequently seen in patients with diabetes with complications, that is the group 1, in comparison with patients with diabetes without complications. A significant finding which we saw was that even healthy adults had few capillary changes like microhemorrhages, angulated capillaries, and also tortuous capillaries. Probably the microhemorrhages could be a result of their occupation also. You can see this is a picture depicting here we have this black arrow pointing towards a dilated capillary. This is a dilated capillary, and these capillaries, as you can see, the violet arrow points out to the capillaries which haven't reached the distalmost end of the capillary loops. So these are called as the receding capillaries. In this picture, we can see that there is a budding or a loop arising from the main capillary loop. This is called as a budding capillary, which represents or which indicates neoangiogenesis. Here you can see that there is a figure of 8 appearance or a crossing of a capillary loop onto it over the opposite end. This is meandering capillary. You can see here the black arrow points out towards a dilated tortuous capillary, and this is an angulated capillary, that is the two capillary loops is bent at an angle, and this is pointed out by using a blue arrow. Coming to the nail fold capillaroscope, we also tried to analyze the nail fold capillaroscopic changes in terms of the glycemic levels, and we divided the patients with HbA1c into 2 groups based on their HbA1c values, that is HbA1c value less than 7 in one group and a HbA1c value more than 7 in another group. So what we found was that few parameters like the tortuous capillaries, receding capillary dilatation, and meandering capillaries were almost high or similar relatively higher in patients with HbA1c more than 7. While few other parameters like neoangiogenesis, avascular areas, dropouts, and microhemorrhages and angulated capillaries were seen relatively higher in patients with HbA1c less than 7. However, there were few findings like the bizarre capillaries, which were not statistically significant. All the rest of the findings had a p-value less than 0.05. Indicating that these findings are statistically significant. This is a picture depicting the subpapillary plexus. As you can see, there is a network of capillaries which are arising from the proximal loop and branching over onto the distal end. Then we try to analyze the capillary findings in patients with retinopathy and without retinopathy. and divided them into two groups. What we could find is that the tortuous capillaries were seen, almost all the capillary findings like the tortuous capillaries, receding capillaries, capillary dilatation, the meandering capillaries or the bushy capillaries, almost all the capillary findings except avascular areas were relatively more frequently seen in patients with retinopathy compared to the patients without retinopathy. However, the p-value was not significant in almost all the parameters. That is, the p-value was almost more than 0.05 in almost all the parameters. We also tried to analyze the capillary findings in patients with nephropathy and without nephropathy, and also with neuropathy and without neuropathy. What we found was even though the proportion of the number of patients with having nephropathy and retinopathy was small, the findings were relatively higher in patients with nephropathy. That is, around 78% of them had a higher frequency of had tortuous capillaries compared to only 57% in patients without nephropathy, while the proportion was higher even for receding, for capillary dilatation, and also for meandering capillaries. A similar proportion was also seen in patients with neuropathy and without neuropathy, with patients with neuropathy having a higher frequency of nail fold capillaroscopic changes in comparison with patients without neuropathy. As you can see, almost all the variables had a p-value less than 0.05, indicating that these parameters were statistically significant. Apart from that, we also tried to analyze patients with, we also framed patients into the two groups, that is, patients who had metabolic syndrome satisfying the at least three criteria for metabolic syndrome, and divided them into patients with metabolic syndrome and without metabolic syndrome. Here also we found that except for tortuous capillaries, almost all the capillary findings were relatively more frequent or had higher proportion in patients with metabolic syndrome compared to patients without metabolic syndrome. However, the p-value was not much significant in almost all the capillary findings. Coming to discussion, in our study, if you can see, all the three groups had a similar or comparable age and gender distribution. There was a higher frequency of positive family history in group 1 compared to group 2 and 3. Also, the proportion of patients with hypertension were more in group 1. The mean disease duration was also high in group 1 compared to group 2. The most common NFC parameters in healthy controls in our study were tortuous capillaries, dilated capillaries, angulated capillaries, microhemorrhages, and meandering capillaries. The most common NFC parameters in type 2 diabetic patients were tortuous capillaries, dilated capillaries, meandering capillaries, microhemorrhages, neoangiogenesis, and also the decreased capillary density. We found that the patient with improper glycemic control or HbA1c value more than 7 had more frequent NFC changes of tortuous, receding, dilated, and bushy capillaries compared to the ones with proper control of diabetes, while all other parameters were more common in patients with HbA1c less than 7. The reason probably could be HbA1c reflects only the glycemic index of the past 3 to 4 months, while the microvascular changes or the alterations may require long time to manifest. Hence, this probably could not be a better indicator to grade them as having nail fold capillaroscopic changes. We also compared the NFC changes among patients with retinopathy and without retinopathy, but we couldn't find any statistical significance, even though almost all the parameters were seen more frequently in patients with diabetic retinopathy. In our study, while comparing the patients with and without nephropathy, we found that the proportion of NFC changes were more frequent or more common in nephropathy as well as neuropathic groups. In our study, it was also found that patients who fulfilled the criteria for metabolic syndrome had relatively more frequent nail fold capillaroscopic changes compared to the ones who didn't fulfill the criteria. However, this difference was not statistically significant. Coming to the previous studies, Suver et al. Stated that the capillaroscopic findings like tortuosity, bushy capillaries, neoangiogenesis are more frequent in patients with proliferative retinopathy compared to those with than non-proliferative retinopathy. Bakitchi et al. Found that the rate of patients with tortuous capillaries, ectatic and giant capillaries, neoangiogenesis was higher in diabetic retinopathy positive group. And in our study, almost all the capillary changes except the avascular areas were seen more frequently in patients with retinopathy than without retinopathy. Chang et al. In their study reported a positive correlation between diabetic retinopathy and tortuous capillaries, bushy capillaries, and enlarged capillaries. The frequency of almost all morphological forms were relatively higher in group with microvascular complications versus without complication in study by Deepak et al. The frequency of avascular areas was higher in our study compared to the study done by Deepak et al. Maldonado et al. Showed that there was an association between microangiopathy seen at ophthalmoscopy to the presence of avascular areas and ramified capillaries in the nail fold. Young et al. Reported that the capillary architectural derangements positively correlated with albuminuria in type 2 diabetic patients. In patients with hypertension, the most common NFC nail fold capillaroscopy changes were meandering capillaries, dilated capillaries, avascular areas, bushy capillaries, and microhemorrhages, as reported in Mishra et al. Study. Conclusion: capillaroscopic changes were more frequently seen in diabetics with microvascular complications compared to those without microvascular complication, and the NFC changes correlated well with the microvascular complication. Thus, they can help as a non-invasive tool to identify patients at risk and should be recommended to be done in all diabetic patients at their visit to the OPD. The limitations for our study was that we included even the patients with hypertension, and we couldn't attribute whether the NFC changes were solely because of diabetes or the microvascular complications associated with it. Also, in our study, we had a very small group of patients with nephropathy and neuropathy. A larger sample size study with different demographic population may have provided a better picture of the NFC changes. These are my references. Thank you.
Thank you, Dr. Sanjay, for wonderfully presenting your thesis on the utility of nail fold capillaroscopy on diabetes mellitus. So moving on to the next talk, and I'll be talking about how to, Dr. Sanjay, if you can stop sharing your screen. Yeah, thank you. Thank you. So I'll be talking about how to prepare a report for the nail fold capillaroscopy, and my job is made easier by the previous speakers who have wonderfully elaborated about the various aspects of nail fold capillaroscopy. So this presentation would be a checklist of the various things that you have to keep in mind or you have to record while you're doing nail fold capillaroscopy for your patients. I bring greetings from Nail Society of India, and I have no conflict of interest and no financial disclosures to be made. The objectives of this talk would be to prepare a report for NFC, and it would be divided into the patient details about the description of the device and what all examination details that have to be necessarily reported during your NFC reporting. So starting with the patient details, and they start before you start performing a nail fold capillaroscopy. So you should always make sure that the patient has undergone a period of acclimatization. You should always make sure that the patient has removed the nail polish prior to the procedure. You can ask the patient if they are already having artificial or the gel nails to be removed before you call your patients for the procedures. You should ask the patients to avoid any manicures prior to performing the NFC. And you should always kind of mention about their jobs and the hobbies that they might be having. So that you can actually have an idea about any traumatic factor that might be taken into account for the nail fold capillaroscopy. The patient should also be asked about their physical activities, outdoor and the indoor activities. The patient should be asked about their dominant hand, because the dominant hand fingers might be more predisposed to the trauma and might show some confounding factors while reporting the NFCs. The patient should be asked about specific medications. It becomes a very important role, and you should always specify on your reporting form all the medications that the patient might be taking, because some of the medications like the beta-adrenergic blockers, the vasodilators, the anticoagulants, antihypertensive drugs, and other agents with vasoactive effects like the marijuana, the cocaine, the amphetamines might alter the findings in the nail fold capillaroscopy. Patient should be asked about their comorbidities, because there are certain comorbidities which are very much common in the elderly age groups, like the diabetes, mellitus, hypertension. We have already seen in our previous presentations that how these comorbidities might be associated with NFC changes in themselves. So they might provide you a different picture when you are seeing these patients with comorbidities as well as connective tissue disorders. Patients should be asked about the recent finger trauma, nail biting habits, or any other habit of self-injuring the cuticles. You should also report and ask the patient to provide a detailed description of the digital color changes, and which will give you a clue towards the history of the Raynaud's phenomenon. You should specify whether the examination is performed during the Raynaud's attack. Why? Because capillaroscopy ideally should be avoided during the Raynaud's phenomenon attack. Patient should be asked about their age, because as Chander ma'am has told that, you know, how the pediatric age group and the elderly age group, they can have a variation in the nail fold capillaroscopy as compared to the adults. And the patient should also be asked about the history of digital ulcers. Coming to the second aspect of the reporting, and that is the device description. Very important, because as we have seen, you know, a number of devices can be used for performing nail fold capillaroscopy, and all these devices have their own advantages and disadvantages. So you should specify in the form what device are you using. And a very important point, which the previous speakers have also highlighted and elaborated, is that now the standard protocol is to do nail fold video capillaroscopy at 200x magnification. So coming to the device description, the make and the model of the nail fold capillaroscopy device should be reported on your form. The details of magnification becomes very important, as we have seen that, you know, as low as 10x and as high as 200x can be used for the reporting of the nail fold capillaroscopic images. If you are using any automated grid, that has to be reported. Some people do use, and some devices do give these automated grids, which can help you, you know, kind of quantitatively assessing the number as well as the morphological changes in these capillaries. The use of immersion oil or any other immersion fluid that you are using for your procedure should be reported, and the details of the computer software, which if in case you are using for the calculation of the quantitative and qualitative features, has to be reported on your form. Coming to the examination details, and the details starts with the physician or the dermatologist who is doing these nail fold capillaroscopic examination, and details of the experience and qualification of the dermatologist should be highlighted onto the form. In case more than one examiner are there, the training of each examiner should be mentioned onto the report form. The number of fingers which are being examined has to be written down. It should be reported which finger has been examined and which has been excluded. Each finger should be analyzed separately and therefore has to be reported separately. I'll show you in the subsequent slides how I do it. Image of each finger should be coded, numbered, or stored. You can have your own way of coding and numbering these fingers, or you can just alphanumerically name these fingers, as right and the left hand fingers. The reason for finger exclusion should be reported. The number of image collected at each nail fold should again be reported, because you might require more than 2 or 3 images at a particular nail fold, especially when that particular nail fold is showing various kind of features in the different fields. The details of the image quality and the missing data should be reported, and details of the global condition of the hand as well as should be reported, as was highlighted by Dr. Shazia, that sometimes the patients with systemic sclerosis might have these flexion contractures, and therefore you should report the global condition of the hands as well. The details on the image reading should be reported, like who is reading these images and how you are blinding these images, especially when you're doing a study. You should report the overall pattern first, whether it's a normal pattern, the stereotype normal, or the non-specific abnormalities are present, or whether any abnormal scleroderma patterns are seen in your patients. And also you should report the validated scleroderma patterns in the form of the early, active, late, or scleroderma-like features, which have been dealt with in the previous lecture. So I'm not going into the details of these patterns. So this is the performer that I usually use for the examination details. I usually divide it into right and the left aspect, and I start my examination with all the fingers. I do all the 10 fingers at the beginning of my examination, and then divide them into right and the left fingernails. Also important to understand is that never miss the ring finger and the small fingers, because the literature suggests and supports that these are the two fingers where the visibility of nail fold capillaroscopic features are maximum. So always try to take as many number of images as possible in these two fingers of both right and the left hand. And minimum which I take is 4 images, so that I have the number of capillaries in an area of 4 millimeters. Now, morphological measures, again, I record into right and the left hand, and I start with all the fingers, and I just tabulate these features as plus and minus, whether they are present or absent. Also, if I feel like I can quantitatively measure the number of dilations, the number of bushy capillaries, I write the numeric forms also in addition to the plus. This is the left hand. This is the subsequent slide where I've measured, where I've written the various NFC morphological changes in these while doing the examination for my patients. Also, it's a very good idea to have this kind of image in your reporting form, because you can just highlight, you can do a color coding of the fingers, you can do the alphanumeric coding of these fingers, because sometimes when you're doing nail fold capillaroscopy for your patients, you might be having more than 20-30 images on your desktop or on your phone. So it might become difficult for you to understand which image was done for which fingernail. So it's always a good idea to kind of label those fingers accordingly. Like alphanumeric is one form of labeling it, color coding is another form of labeling it. Suppose you want to do the right hand, you can just label it as red, left hand can be labeled it as blue, or vice versa. And also, if you're doing the toenail nail fold capillaroscopy, also you can highlight, or if you're skipping that, you can just put a cross over that finger that you have excluded that finger, and you can just write it down there, what was the reason of exclusion in that particular fingernail. So this concludes the reporting. So it's an easy process to do, but if you go step by step, if you take into consideration all these things, if you prepare an elaborate report about your patients, there's very high chance that you might be able to diagnose a particular disease, especially the connective tissue diseases, very early in their disease course. Thank you so much. So I'll be taking the questions which have come from the audience. So we have received some questions from the audience, and I'd like to have the attention of all the speakers. So the first question is from Dr. Arpita. What is the difference between capillary width and apex width? Dr. Chander Grover, ma'am, if you can please elaborate.
Yes, Dr. Deepak, this capillary width versus the apex width, if you'll just allow me to share my screen again, because it's difficult to explain like this. So I just downloaded an image to show. Is it visible?
Yes, it's visible.
Yeah. So this shows the difference between capillary width and apex width as per literature. So here you can see, and with a disclaimer that these measurements are very difficult to do with the USB dermatoscope with the standard 180-200x magnification that we are talking about. So capillary width is going to be this much, right from the outer wall of the afferent limb to the outer wall of the efferent limb. This much is the capillary width. And as the capillaries dilate, the capillary width keeps on increasing. So with giant capillaries, this is the dimension that we are talking, which is going to be 10 times. And apex width is near the apex, as you can see here. So apex width by default is less than the capillary width. But this is difficult to calculate with the measurements that we are doing, and it will be applicable only for a very standard arranged dilated capillary. Now, when these capillaries start ramifying or becoming bushy or becoming, like we talked about, the disarray and the disorganization, then it will be very difficult to calculate apex width, and capillary width will be the term which will be more applicable for such a vessel.
Thank you so much.
Thank you.
Dr. Nirmal B, sir, you have worked with both handheld as well as the more sophisticated device. So which one, in your opinion, was more helpful or more easy to use, in the busy OPD setup?
Yeah, handheld is used for screening basically. Like, you want to see, you want to check it very fast. Like, handle will be very useful. And once you find abnormality, once you really want to do research on you want to measure the capillary width, or you want to measure the CSUR index, then probably subject the patient. You ask the patient to come a little later, or on your non-OP days, you ask the patient to come, and then that takes about half an hour. But with the handheld dermatoscope, you can very quickly screen and see whether it is normal or abnormal. So that's for screening, and this is for research.
This is for research. Yeah, absolutely correct, sir. And Dr. Shazia, you have talked about using handheld dermatoscope, and do you have a specific technique for calculating the mean capillary density with the help of that handheld dermatoscope? Dr. Shazia, if you can hear me. Okay, Dr. Kumudhini, if you can come in, how do you, what method do you use to calculate the mean capillary density with the help of a handheld dermatoscope? I think both of them are not there. So we'll move towards the video dermatoscope actually. Dr. Sanjay, are you there?
Yes, sir.
Yeah, so you've done your thesis on diabetes mellitus. So what method did you use for calculating the mean capillary density?
Sir, I tried to analyze the images by after marking the center of the proximal nail fold with the pen.
Mm-hmm.
I tried to count the distalmost capillary loops over the 2 millimeter length.
Okay.
On either side of this point, sir. And this.
Okay, so you use that 4 millimeter.
Yes.
4 millimeter. Okay, method. Okay, yes. Fine. Chander ma'am, can you tell us about the utility of interface medium, if you use any?
Yes, in doing nail fold capillaroscopy, we find it especially useful. Like there are changes in the nicoscopy which you can still pick up, or you need to pick up without the use of interface medium. You want to do the dry nicoscopy, but NFC is best done in a wet scenario only. So you need a linkage fluid to increase the transparency, and will be especially even more useful where transparency is otherwise low, because like in patients with systemic sclerosis or in diabetics, skin tends to be a lot dry and you have the cracked cuticle and ragged edges, lots of dryness. So that is needed to settle the scale so that you can actually see the capillary morphology nicely.
Okay, and ma'am, any specific method do you use to apply it uniformly? Anything to ensure?
To apply it uniformly, see, at present, what we are doing with most of our dermatoscopy is use the sanitizer fluid, the sanitizer gel, which is available on the table because you're using it anyway. But what we realize is with nail fold capillaroscopy, because it is slightly more time-taking procedure, the sanitizer dries up very fast. So you need something which stays for some time. So for the contact dermatoscopes like the handheld, you can use ultrasound jelly. Here, the word of caution is it should be brought down to skin temperature before using it, because normally we keep it in the fridge and it is cold and it can cause capillary constriction. It should be brought down to skin temperature first. And the other way is to use immersion oil on the proximal nail fold. Various techniques are available for that. Also, to apply, how to apply. but we use what you have devised, Deepak, the highlighter pen, in which we have like removed the ink, and after that immersed the sponge of the pen in immersion oil, so that we apply it like a pen over the proximal nail fold. I think you can explain it better.
So basically, it's the highlighter pen that we normally use for the books. So you can just drain out the ink, and because it works on the principle of imbibing that particular ink, so it can imbibe the immersion oil as well. So based on the capillary action, it will start working as soon as you fill it with the immersion oil, and you can start it using on the proximal nail folds. Of course, you have to make sure that the nails are not infective. So in that case, you have to use a separate pen for each patient.
And it's easy to store, it'll not spill, it does not cause mess on your table, easy to clean from the nails of the patient, and easy to put it in your kit bag. Otherwise that bottle, if it spills, it's a lot of messy this thing.
Thank you, ma'am. Nirmal B, sir, there's a question by Dr. S. Vanilla. She's asking, are the changes that we see on nail fold capillaroscopy, are they reversible with treatment? And
Yes.
can we have the modality to assess the prognosis and disease activity during treatment?
Yes, it does reverse, especially in mixed connective tissue disorders. It tends to reverse really very fast. And when the patient responds to steroids. So, but late changes, they don't reverse. At least the early changes, like, once you actually follow the patient, like, you can see it to reverse over a period of time.
Yeah, right. So it can be used for the.
It can be used to assess the prognosis, whether it is whether disease is progressing or the disease is regressing. It does reverse.
Yeah, I have one more question for you, sir. You talked about how you did nail fold capillaroscopy at CMC Vellore, and also after that you got training. So is it easy for us dermatologists to start doing this, or is there any specialized training which is required prior to doing nail fold capillaroscopy?
See, to identify whether a capillary is normal or a nail fold is normal or abnormal, I think it's enough if you get a little bit of training, or attend a few online courses. Then it becomes a little more easier whether to identify it, whether it is normal or abnormal. But it comes through practice. Like especially when you're looking at looking with the handheld dermatoscope to identify, especially when you don't have quantitative parameters, whether there is dropout is there, dropout is not there, whether it is dilated, which is normal, which is abnormal. To identify that, I think it comes by practice. But like over a period of time, you'll be able to really make out identifying whether the nail fold capillaroscopy image or the what you see is normal or abnormal. That comes very very easy with time, but it needs a bit of practice.
Are there any training centers as of now in India where if someone get a training maybe for a couple of weeks?
I think Dr. Chander must be knowing it. I think you have a short training in UCM. I'm not very sure, but I'm not very aware of it.
Chander ma'am, can you please?
No, none that I know of. I think we do all the in-house training, and learning from each other is the process with which we are progressing. None that I know of.
Thank you, ma'am. So Dr. Shazia has joined us. Dr. Shazia, when you do a nail fold capillaroscopy for a particular patient, how much time do you think you require to complete the procedure for just one patient?
Like if we go for only fourth and the fifth fingernail, then at least 10 to 15 minutes.
So do you call the patients on a separate day, or do you do it in the busy OPD only?
Basically, I told you, no, we don't do it in a busy OPD. Basically, we have a dedicated connective tissue disease clinic that runs on every Friday of our, it runs from 10 to up to 2. And we see almost maybe 10, 15 patients on a daily basis, maybe more than that, but at least 10, 15 patients. It is going to take time. Normally, if a patient of connective tissue disease comes on other days, we refer the patient to the connective tissue disorder clinic. We refer the patient and we try to do them on that particular day only, because it's going to take time. 10 to 15 minutes is minimum time. But keeping the versatility of these handheld dermatoscopic scopes, sometimes a call comes from the medicine side, and we can go there with our dermatoscope, perform the bedside. This is a bedside procedure. We can do it over the bedside. That's the biggest advantage with these handheld scopes.
Thank you. So there was one question which I was asking previously. How do you calculate the mean capillary density with the contact dermatoscope? How do you count the number of capillaries?
Yeah, basically the line that comes with the contact plate, it has markings for it. I just calculate, there are two ways. Either we can calculate it over the whole length, but 10 mm, then we 5 mm, then we can divide it by 5. That gives a average. That's a better option rather than counting it only in 1 mm. That does not give us a good idea. But if we take a complete 1 centimeter and then divide by 10, that gives us a better idea.
Okay, great. Dr. Kumudhini, are you there?
Hi, sir. Yes, sir. I'm so sorry.
Hi, Kumudhini. So, Dr. Vishal Pal is asking, what can we do for better visualization of nail fold capillaries in the darkly pigmented individuals? Are there any tips and tricks for that?
Yes, sir. There is. First thing is, I would like to say, not really all fair skin individuals will be having the same better visualization, and same goes with dark skin. I mean, yes, that's a general consensus. But even in the dark skin, if we do not press it a lot, like definitely the gel helps a lot, and we should make sure the SLR camera which we fitted on the dermoscope doesn't press the the nail fold, because whatever minimum capillaries which is visible will be like blanched out. So that is one thing. We should not put in so much pressure. And yes, using the gel and keeping it at a distance, it works, because I do have a lot of good pictures with dark skin individuals as well. So I think, but there is some subjective difference. This is something which we can try.
Nirmal sir, if you can come in.
Yeah, one thing is, like, if you have a derm light DL4 or a derm light multispectral dermatoscope, there is a orange light there. So, or a yellow light there. That increases the contrast, like it helps to negate the reflections, and that penetrates a little more deeper than your white light, and that with which, like, vessels will be more prominent against a darker background.
I think that's a very useful tip which you have just said. So still, there are certain patients, no matter what you use, even the fair-skinned individuals, no matter what you do, the visualization of capillaries is very much variable. So is there a standardization of procedure which can, kind of ensure, or is it just the individual variation which we are seeing? Nirmal sir?
It is difficult, like how you have how you do dermatoscopy on a dark skinned individual on the face. It's the same thing with the nail fold. It is difficult. You need to accept that. Like it's not the same as you see in fair skinned individual. And initially, like, we had a few residents coming from abroad. So to find, I mean, for me, like my initial nail fold capillaries, I used to see nail folds, like, look at nail fold capillaroscopic from. So that is the way by which you can learn things. And after that, like, your eye gets trained, and you will know, like how to visualize those capillaries in a dark skin also. It is visible. It takes a bit of practice. So maybe initially when you're trying nail fold capillaroscopy with the dermatoscope, you can start with the fair skin. You can see lighter skin. You can see normal nail fold capillaries through the lighter skin, and then you can go for dark skin.
Okay. Dr. Shazia, there are certain, connective tissue disease patients where we see a complete loss of nail in them. So do you still go ahead with the nail fold capillaroscopy? You're muted, Dr. Shazia.
Yeah, just a second.
Yeah, now you're audible. Yeah.
Yeah.
So do you
The other slide that I showed you of the patient, that patient had loss of finger tips and the background was completely hazy. It's not really possible to look for the naval capillaries in those particular patients. Sometimes what we see, there are gross avascular areas in those late stages of the disease, like the late stage of the connective tissue disorder, where there is skin is tethered, and it is characterized because the background, hazy background, comes as one of the characteristics for the late pattern of the systemic sclerosis. That itself gives us a clue that the disease is already later stage, advanced stage of the disease. And in those patients, it's really difficult to see the change in the needle capilloscope.
And Dr. Kumudhini, any tip to kind of examine the thumb, because thumb I think is the most difficult to visualize as well as to examine while doing the NFC.
Yes, sir. I've actually not seen one proper finding in the thumb yet, and I would always like take my dermatoscope to the bedside and always examine. But whenever I find difficulties, like for even in the dark skin or in the case of like thumb, when we don't have other choice of visualizing the other nails, I would recommend shifting the patient to the department and using the video capillaroscopy, the nail fold capillaroscopy, or the video-dermatoscopy, because the magnification is much more. So in the dermatoscope, I'm still here to figure out seeing better results on the thumb. So I actually don't do that.
Yes, yeah, I totally agree. Nirmal sir, other than systemic sclerosis, I mean, they have a defined criteria and it has been included in the ULR criteria. Are there any other diseases as far as the connective tissue diseases are concerned where there is a specific criteria for kind of monitoring NFC?
You don't have a specific criteria because like none of the other disorders are studied well or extensively as compared to systemic sclerosis. Other thing is like not all these patterns like which I spoke about are seen consistently in other disorders like mixed connective tissue disorder. It's about the sensitivity of that of nail fold capillaroscopy in those are the other disorders. Mainly like you can actually divide the pattern into systemic sclerosis dermatomyositis pattern and SLE or a non-specific pattern. Usually SLE and Sjogren disease will come into the other pattern, and MCTD, dermatomyositis and systemic sclerosis will share the same pattern. But none of the other disorders have been actually studied as extensively as systemic sclerosis.
Dr. Shazia, beyond connective tissue diseases, do you use NFC for other general dermatological conditions?
Not for the dermatological conditions, but we were planning to do it on the diabetic patients, because diabetics, they have enlarged capillaries. So we were planning just to do like a study how we are going to see it in the diabetics.
Are you there?
Yeah. Hello.
Chander ma'am?
Yes, I'm there. Yes.
Yeah, ma'am, you have guided thesis on diabetes, mellitus, and hypertension. So how easy it is, kind of do it's an interdepartmental thesis. How easy or how difficult it is to, kind of carry on with these kind of theses?
So with respect to the easiness, there are two parts to this dynamics, I think. How easy it is interdepartmentally, or whether the patients are motivated or not.
So both ways.
Both ways. So basically, the point is that the interdepartmental variations will vary from institution to institution. We have been fortunate enough to get a good stream of patients, because otherwise also we are blessed with quite large number of patients. So it's not easy. From our OPD also we can get so many diabetics and newly diagnosed hypertensives from which we were able to do these thesis, one yours and one Arzoo's. And the second part is whether the patients are motivated enough or not. So in that scenario, I can only say that longitudinal follow-up becomes a difficulty, but cross-sectional analysis is not much of an issue. So according to literature, that was one of your earlier questions. According to literature, the changes in nail fold capillaroscopy are reversed supposedly in patients with arterial hypertension with effective management of their blood pressure. But we have not been able to see that because with us, the longitudinal follow-up is an issue.
Thank you. So there is one more question. It's guided towards me. How to prepare a report? Are there any prepared formats available which can be downloaded and used? So the various points which I've showed in my PPT are from an international consensus criteria, and all the points which I've highlighted are the most important points which have to be kept into the report. I am not aware of any downloadable formats which are available.
But you can prepare one and make it available on the NSI website.
It can be.
Right. Yes.
So with that, we come to the end of this panel discussion. I would like to thank all my panelists and all the speakers for giving their valuable time to this unique, I think it is one of the first nail fold capillaroscopy entirely dedicated workshop. So with that, I'd like to finish this panel discussion, and I would like to invite Dr. Vineet Elan sir, who is the Vice President, Nail Society of India, to conclude it.
Thank you so much, Deepak. And I would like to really appreciate his effort today. He has single-handedly done this today. Chander was preoccupied with some family issues, and I was also traveling today. So thank you so much, Deepak. And this brings us to the end of the fourth skill-based NSI webinar series, which have been held with the educational support from the Linux labs. And today also we have crossed more than 300 viewership. There are 300 people logged in, more than 300, I think. So that's a very good achievement. And there are certain some important announcements to be made. My screen is visible?
Yes, sir, it is visible.
Yeah. So, first of all, I would like request all the people to log into our website, nailsocietyofIndia.com, and the membership is very nominal, 6,000 rupees. Now we have added a facility. You can online transfer the money also and just send the receipt to me or Dr. Khushbu. 10th Annual National Conference of Nail Society of India on ICOCON 2021 will be a virtual conference. It will be held on 13th and 14th of November 2021. And the theme of the conference is celebrating nail science. So for more information, you log on to our website, nailsocietyofIndia.com or Nail Society of India or Facebook page. The abstract submission dates, the last day for submission of the abstracts is 24th October 2021, and you can submit original studies, case series, interesting nail cases, and you can mail these abstracts to abstracts@gmail.com. And please quote your NSI membership number when you submit these abstracts. The membership of NSI is mandatory for all things. We have a Systopic NSI Thesis Award that carries attractive prices, and send your abstracts to abstracts@icocon@gmail.com. Again, the NSI membership is mandatory, and the last date I've already told is 20th October, and the acceptance will be conveyed by 30th October 2021. We have an interesting nail quiz, and the quiz prelims will be on 13th of October and quiz finals on 14th of October. So I request all the senior faculty members to encourage the PG students to participate in this quiz. That's all. Thank you so much. And once again, thank the Linux Labs for their support. And today was a very special day. We had senior members, Dr. Marfatia also coming up with a talk. And after a long time, I could see Dr. Nirmal B, a very close friend of mine. Thank you so much. And just register fast for the on ICOCON, 10th on ICOCON. Thank you so much. Okay, Deepak, anything more?
Thank you, sir. That also.
So can we go offline?
Yeah, thank you.
Dr. Elan sir, can we go offline?
Yeah.
Yeah. Stop live streaming now.